Okay, so if we take tungsten as a most important element, which is used in the intraoral that is in the IOPM machines, the binding energy of the tungsten with respect to the K shell is more than that of the L shell, than that of the M shell. Okay, so that is why the tungsten has the higher atomic number, which can produce so much of reactions, and hence tungsten is actually chosen as an element to produce X-rays. Okay, so here you need to know that the tungsten is an atom which is used to produce the X-rays, and the binding energies of the tungsten in K shell is 70, in L shell is 12, and M shell is 3. Okay, the shell which is very close to the nucleus is the K shell, which has only 2 electrons, and the L shell is the next to that of K shell, which has 8 number of electrons, and the M shell is the electrons is next to that of the L shells, and the energy, the binding energy is 3 keV. Okay. So X-rays are produced in the anode, cathode, the glass wall, molybdenum focusing cup. So the option is anode. From the cathode, there will be a series of electrons which after the thermionic emission will hit the anode and the X-rays will be produced. Okay. So this is the tube head, and this is the control, this is the extension arm, and this is the control panel. Okay. You may also get certain picture images, which why I'm adding so much of picture is that you may also get some of the picture images. So this is the control panel where you can control all the settings in the IOPM machine, and this is the tube head, and inside the tube head is the is all this apparatus. Okay, all these reactions takes place only here. Okay, so the next picture is a diagrammatic representation to tell the production of X-rays. So this cathode is made up of tungsten filament in the molybdenum cup, and the anode is angulated at 20 degree, which is called as the angle of truncation. And this this anode is also made up of tungsten, and this is suspended in a copper stem. Okay, so since copper is a very good conductor of heat, the copper is used as a in order to dissipate the heat. Okay, so once exposure, the tungsten filament will be heated to incandescence. Okay, and then there will be flow of electrons from the cathode to the anode in the effective focal spot. Okay, so you must be knowing that the dimension of the actual focal spot is actually 1 into 3 millimeter, which is angulated to 20 degree, called as the angle of truncation, and this angulation is done to get a good quality of X-ray beam. Okay, so once the X-rays are produced, the X-rays will have different energy, the high energy and also the low energy. So the low energy X-ray beam will be filtered by means of inherent filtration and also by means of added filtration, which is different for different machines. And then this X-ray beam will be collimated to the particular beam which is needed for diagnostic purposes by means of a lead collimator. Okay. So this entire system is evacuated by means of a glass tube, so that no reactions takes place. Okay, so the oxidation of the substance or no other reactions takes place inside the machine, so it is evacuated. Okay, you need to know each component of the X-ray tube, what is the function of each component, and that may be separately asked as the MCQ question. Okay, so the 3 different types of used, one is the step up transformer, the step down transformer, and auto transformer. Okay, so 3 different types of circuit is also there in the intraoral IOPA machine. So here heated up to incandescence, and the electron cloud is produced, and once after the exposure, this electrons just pass on from the cathode to the anode, and it produced X-rays. Okay, and these X-rays are divided into different types based upon their wavelength. Okay, so the one which is used for the industrial röntgenography is the hard X-rays, and one which is used for the diagnostic purpose is the medium X-rays, and soft X-rays are those which is used in the contact therapy, and GRENs or super soft X-rays are used in the treatment of superficial lesions. So all this you can just take a screenshot so that you can make use of it when you have free time. You can read it with the different values. Okay. So these are all some of the facts which you need to just remember. So the target of the X-ray tube is angulated to produce all the following effects except. So the target is the anode. Okay, so எதுக்காக வந்து அதை angulate பண்ணிருக்காங்க அப்படின்னு கேக்குறாங்க. Okay, so to decrease the focal spot, to increase the image sharpness, to energize the photons, to dissipate the heat. So here the question is except. Okay, so to energize the photons. So obviously it is angulated to decrease the focal spot, to increase the image sharpness. So from the actual focal spot to effective focal spot, image sharpness is something which is very important, because if the image sharpness is not maintained properly, the image shadow will be more. Okay. And the next one is the angulation of this is about 20 degree, because it has to dissipate the heat. Since so much of reaction is taking place in that particular point, so much of heat will be produced, and hence it is angulated to dissipate the heat. Whereas the energization of the photons is not done by the target angulation. It is actually maintained by the potential difference. Okay. So reducing the size of the X-ray beam is achieved by filtration, photoelectric effect, collimation, Benzold-Brook effect. So reduction of the size is mainly by means of collimation. Okay. Collimation அப்படிங்கிறது உங்க எக்ஸ்ரே பீம் வந்து எவ்வளவு பெருசா இருந்தாலும் அதை வந்து ரெடியூஸ் பண்ணி எந்த பர்டிகுலர் ரீஜன்ல நீங்க எடுக்கணுமோ அந்த அளவுக்கு காலிமேட் பண்றது தான் வந்து it is collimation. Filtration is something where you remove the low energy X-ray photons. Okay. And photoelectric effect is something which is related to the effect or the interaction of the X-rays with that of the matter. Photoelectric effect, Compton effect, and coherent effect. Okay. Benzold-Brook effect is with respect to your rotating anode. Okay. So here the options also we can discuss, because some of the questions are formulated with the options also. Since we can't discuss all the questions in the 3 hours, so we'll discuss with the options also. So the X-ray collimators commonly used in dentistry include the following except the diaphragm collimator, tubular collimator, rectangular, square collimator. Okay. And it is actually except. The question is actually except. So the option is D, square collimator. The rectangular collimator and the circular one is actually used in the IOPA, whereas the tubular is used in the OPG machines. Okay. Square collimator is not used anywhere in the dentistry. Okay. The commonly used in collimator devices: aluminum filter, lead diaphragm, molybdenum cup, tungsten filament. So here the option is lead diaphragm. So lead is a collimating device, whereas the aluminum is a filtration device. The molybdenum cup is the cup which actually holds the tungsten filament, that is the cathode, the component of the cathode, and tungsten filament is also a component of the cathode. So this is a diagram which shows that if you use a round collimator, and if this is the IOPA film which you use, this amount of the skin will get excess of radiation. Okay. So நீங்க round collimator யூஸ் பண்ணி ஒரு IOPA film எடுத்தீங்க அப்படின்னா, இந்த சுத்தி இருக்கிற இந்த shaded area இருக்குது இல்லையா, இது வந்து will get excess radiation. So if there is a question like which collimator is best, அந்த மாதிரி ஒரு question option இருந்துச்சு அப்படின்னா, it is obviously the rectangular type of collimator. Okay. So since it can actually fit the IOPA film, there will be no amount of excess radiation which is exposed on the skin. Okay. And the dimension of this is almost 2.5 inches. Okay. So this is called as a position indicating devices. This is the tube head and this is the lead collimator. Okay. And when you use a short cone, if the position indicating device is small, then the exposure will be large. If the position indicating device is long, okay, long cone, short cone technique, if the position indicating device is long, the amount of exposure to your skin is very less. If the position indicating device is less, then the amount of exposure is more. Okay. So based upon this, you will be getting some of the statement questions. Okay. So if you remember this diagram or take a screenshot of this, you can actually answer it. So all of the following are true except, again, exceptional question. So use of speed E-film reduces radiation exposure. Use of rectangular collimator decreases density. Use of rectangular collimator is indicated to decrease the radiation exposure. Use of collimator is recommended to reduce the size of X-ray production. So here the option is option B. Okay, so the collimator doesn't have anything to do with the density. It is only the exposure. Okay, so speed depending upon the crystals which is present in the IOPA film, the IOPA films are divided into speed A to speed F வரைக்கும் இருக்கு. Okay, so இந்த crystals வச்சிட்டு speed வந்து differentiate பண்ணுவாங்க. So next is collimator is something to reduce the radiation exposure. It doesn't have anything to do with the density. So the best option is B. The inherent filtration of X-ray machine ranges from dash thickness of aluminium. Okay, 0.5 to 2 mm inherent filtration. So remember that when I told you about the filtration part, there are 3 different types. Okay, inherent, added, total. Okay, so inherent is something which the machine inherits. Added is something which you add according to the KVP. Total is one which is a combination of inherent and added filtration. Okay, so the inherent filtration of X-ray machine, normally it is 0.5 to 2 mm. Okay, the filters of which metal is used to remove long wavelength X-rays from the primary beam. Okay, so here the option is, we have discussed already, it is aluminium. Okay, so this is also one of the facts which you need to know. Since I told about the inherent filtration, you must be thinking when to use the additional filtration. Okay, so if the machine is working at a KVP of 30 to 120, aluminium is used, normally an IOPA machine. If it is more than that, copper is used, and again more than that, tin is used, then lead. Okay, so these are all the different elements which is used based upon the KVP. Okay, so the aluminium is most commonly used in the IOPA machine if it works at a KVP of 70, and the thickness here is 1.5 mm if the KVP is 70. If it is more, it is actually 2.5 mm of aluminium. Okay, and the wedge filters are used in radiotherapy. Okay, so you may get a question like, what are all the different type of filters வந்து கேட்பாங்க, which type of filters are used in radiotherapy? So we have seen about total, inherent, added, now wedge. Wedge filters are used in radiotherapy. Therapy is something where you use it for the treatment of cancers. Okay, and profile wedge filters. Okay, this is used to absorb radiation from not reaching the tissues. Earlier days, while taking Ceph, they wanted a soft tissue profile also. So in order to get that, a profile wedge filters was used. Okay, but now we don't do that. Just know it for your MCQ purpose. Profile wedge filters are one to absorb radiation from not reaching the tissues. Okay. Yes. Rotating anode is mainly used to focus the photons, avoid heal effect, to dissipate heat from the focal spot, increase energy of the photons. Yes, to dissipate heat from the focal spot. So அங்க வந்து IOPA மெஷின்ல ஒரு பக்கமா ஆங்குலேட் பண்ணி வச்சிருக்கிறதுனால heat வந்து dissipate ஆயிடுச்சு. Whereas rotating anode is one which is used in the larger machine, in case of extraoral machines or larger machines, where the heat needs to get dissipated when the anode is rotating. Okay, imagine the anode, a rotating anode, getting a focal spot from different directions so that the heat gets dissipate easily. Disadvantages of grids are used while taking extraoral radiography, that is screen films use பண்ணும்போது எடுப்பாங்க. Okay, normally 2 different types of films நம்ம வந்து எடுப்போம். One is screen films, the other one is digital. What we use nowadays is the digital. அப்போ previously screen films were used to take extraoral films. At that time grids was there. Okay, so main disadvantage of grids is that skin exposure of patient, increased exposure time, doesn't improve the image, overall density of radiograph is increased. So the main disadvantage is that it increases the exposure time. Okay, so grids are made up of alternate radio opaque and radiolucent. Radio opaque is something which appears white on the radiograph, and radiolucent appears dark. Okay, so it is alternatively made up of lead and paper. And also the exposure while using the grids is increased. Okay, so during the production of X-rays, how much amount of electron energy is converted into heat? Okay, so in other way, how much amount of electron energy is converted into X-rays? Okay, so 99% of the energy is converted into heat, and only 1% we are getting as X-rays. So that is why we take so much of effort to actually dissipate the heat, and also to make the machine work properly. The heat dissipation அப்படிங்கிற ஒரு ப்ராசஸை வந்து ரொம்ப நிறைய இம்பார்ட்டன்ஸ் கொடுத்து வச்சிருக்கிறோம், since only 1% of the total energy is converted into X-rays. Okay, so two different types of radiation is produced. Okay, in the X-ray tubes, one is the Bremsstrahlung radiation, the other one is the characteristic radiation. So Bremsstrahlung comprises majority of the radiation production, followed by the characteristic radiation. Okay, what is Bremsstrahlung radiation? It is also called as a near hit breaking radiation, which actually follows the near hit hypothesis. Okay, so நியூக்ளியஸ் கிட்ட பக்கத்துல வந்துட்டு அந்த ஆட்டமை வெறும் டிஃப்ளெக்ட் பண்ணிட்டு this radiation will just go. That is why it is called as breaking radiation or Bremsstrahlung radiation. So the other one is the characteristic radiation, which directly hits the innermost electron in the atom, and in order to compensate this loss, the electron from the next shell will get into this shell, and there will be removal of certain energy or the radiation, which is called as the characteristic radiation. Okay, so this characteristic radiation is very particular to certain elements, and hence the name characteristic radiation. Okay, so the 1% of the X-rays which is produced is divided into two types. One is Bremsstrahlung, the other one is characteristic. Adiliyum nariya produce agiradhu Bremsstrahlung, kammiya produce agiradhu characteristic. Okay, so the interaction of the X-rays with the human or with the structures which we need to investigate is divided into three different types. One is coherent scattering, the other one is photoelectric effect, the other one is Compton. Okay, so the coherent scattering is responsible for fog, the photoelectric for the interactions. Okay, yes, the quantity of the current can be increased by, okay, the quantity of the current can be increased by increased milliamperage, increased time, increased tube current, all of the above. So the option is all of the above. So these are all some of the factors which affect the X-ray beam production. Okay, I'll just give the explanation in a table or column in the next slide. Okay, so in a patient having dense bones, the penetration is best achieved by, okay, so if the patient have a very dense bones, or you need to examine the structures which where there is expected periosteal reactions, which factor you need to increase is the question. So if you increase the MA, that is current, if you increase the voltage, increase the exposure time, increase the developing time. So you need to increase the quality of the X-ray beam. So if you need to increase the quality, you should obviously increase the KVP. Okay, bone dense bone penetrate பண்றதுக்கு number மட்டும் பத்தாது, you need to increase the quality also. So the factors which affect the quality is the KVP and the filtration. Okay, the quality is something which is mainly used to increase the, so that the diagnostic image will be very good. Whereas the factors which affects the quantity is the KVP, MA, exposure time, filtration, collimation, and also the distance from the source to the receptor. Okay, so these are all the factors which affect the quantity of the X-ray beam, and these are the two factors which affect the quality. So some of the proportionate ratios here, all these factors you need to know, and if you want, you can take screenshot. So if the current is increased, the tube current, okay, inge current and the tube current is increased, only the quantity is increased. If the tube voltage is increased, both the quantity and quality. If there is added filtration in the machine, obviously there will be filtration inherently. So it will actually decrease in quantity, and there will be increase in the quality of the X-ray beam and the atomic number. Okay, if the target has a high atomic number, the interactions will be more, the reactions will be more, so that an increase in quantity and quality of the image is produced. Okay, so if there is voltage ripple, there will be decrease in the quantity and quality of the image. So this is also one important fact which you need to know, that is the position distance rule. Okay, so the operator should be at a distance of 6 feet or at an angulation of 135 degree, so that the primary beam doesn't actually affect the operator. Okay, so these are all some of the important precautions which the operator has to take before taking an X-ray. If this is the tube head and this is the primary beam ku 6 feet 135 degree angulation avum. If the radiographer or the operator stands, then there will be hazards. The film badge is a type of identification plate, sonometer, dosimeter, tachometer. Okay. So the option is yes, dosimeter. Film badge is given is actually the measure of the radiation exposure, and it is done by measuring regularly once in 3 months by the thermoluminescent dosimeter, that is the TLD badge. Units of radiation exposure is the units of radiation exposure is Roentgen. So exposure is measured by means of Roentgen, the absorbed dose by means of Sievert, equivalent dose, effective dose, and the radioactivity by means of Becquerel. Okay, so these are all some of the important parameters and also the units which you need to remember. Okay, so some of the direct questions where you should never go wrong. If the effective dose in radiation at 2 meter is 1 gray, at 1 meter, what will be the effective dose? Okay, so in 2 meter, if it is 1 gray, at 1 meter, the effective dose will be 4. So this is based upon the inverse square law. Okay, so the explanation for this question is inverse square law. So when the time of exposure is double, the number of photons generated is double, the energy of photons generated is double, the velocity of photons is double, the mass of the photons is doubled. So if the time of exposure is double, the number of photons only is doubled. Okay. So the fundamental particle present in protons is, so earlier days it was told that the fundamental particles was actually protons, electrons, and neutrons. But later on, again, the protons is actually made up of up quark and down quarks. So here the option is quark. Okay. So let's see about certain questions which with respect to the radiation biology. So the component of the cell most commonly affected with radiation is cell wall, cell membrane, cytoplasm, and DNA. So DNA, which is present in the nucleus, is the most affected component of the radiation. Okay. So though the effects are deterministic or stochastic. Okay. So the effects of the radiation exposure is by means of direct and indirect. Okay, so direct effect is when a X-ray photon hits one particular cell, and if there is a cell damage, then it is direct effect. And if it actually hydrolyzes the water, there will be production of the free radicals, and these free radicals are actually responsible for so many chemical reactions. And in order to scavenge those free radicals, antioxidants are actually given, but these free radicals are the one which causes indirect effects. Okay. And deterministic effects. Deterministic abdina dose dependent abdin ஞாபகம் வச்சுக்கோங்க. Okay, so D வச்சு ஞாபகம் வச்சுக்கோங்க. Stochastic defect is not dose dependent. Even if the person is exposed to one single time of exposure, and if there is any changes in the DNA of that particular patient, they may actually inherit to the next generation. So that is actually stochastic effects. Okay. Either they may inherit the effects to the other generation, or they may actually get certain diseases like leukemia or certain type of cancers. Okay. Whereas the deterministic effect is purely dose dependent. It is actually cumulative. Cumulative அப்படின்னா எவ்வளோ டோஸ் நீங்க கொடுக்குறீங்களோ அவ்வளோ amount of effects only you can actually expect. Okay, so this deterministic effects of radiation is mainly used, or it is mainly implicated in the treatment of certain cancers as radiotherapy treatment. Okay, so the cells which are present, imagine imagine a tumor. Okay, and if the tumor cells which is concentrated at the center will have less oxygen supply. Okay, so this radiotherapy is a treatment modality to actually kill those fast dividing cells, and one particular amount of dose is given to actually kill the cancer cells. So those effects are called as deterministic effects, and the side effects are mucositis, loss of hair, okay, and certain conditions like osteoneedum necrosis. Okay. So which of the following are more sensitive to X-ray? Tooth buds and salivary glands, nerves and muscle tissues, hair and nails, cartilage. Okay. So the most radio sensitive are one which divides very fast. So here the option is, so the best option is tooth buds and salivary glands. Okay. So nerves and muscles is actually a kind of radio resistant type of cells, and followed by that is the cartilage and the hair and nails. The most radio sensitive cells in the body are endothelial cells, epithelial cells, red blood cells, white blood cells. So the cells which has the most progenitor cells are the very sensitive cells. So out of these, the options are the white blood cells. Okay. So this has a list, okay, which are very sensitive. The spermatogenic and the erythroblastic stem cells, whereas the basal cells of the oral mucous membrane, these are all highly radiosensitive. Whereas the acina cells of the salivary glands, the parenchymal cells of the organs like liver, kidney, and thyroid, and the fibroblast are intermediate. Whereas the striated muscles, squamous epithelial cells, and erythrocytes are actually very less sensitive. Okay, when it comes to organs, the lymphoid, the bone marrow, the testis, the intestine, the mucous membranes, all are very highly radio sensitive. Okay, the structures which are from the mesoderm are actually the intermediate type, whereas the muscles and the optic lens are so the effect of radiation is cumulative, fractionized, concentrated, dependent on genetic makeup of the individuals. It is actually cumulative. Okay, so as I told you, the effect of the radiation is actually cumulative. It is dose dependent. In the radiotherapy of the oral cavity, the daily dose which we give is almost too gray in a particular field. Okay, so this dose is given for nearly about 6 to 7 weeks. Okay, 2 gray per day for about 6 to 7 weeks, so that the patient will able to withstand only 60 to 70 gray of the dosage. Okay, so in the substances which is used in case of radiotherapy is actually the cobalt, which is a source of gamma radiation, and certain implants. So the cobalt is used in teletherapy, and radon or iodine 235 is used in a brachytherapy type of treatment. The skin of the patient undergoing radiotherapy will show which of the following after 2 weeks? Erythema, depigmentation, radiation-induced carcinomas, no change. That is, as soon as the treatment is started, what are all the changes which we can accept? it is actually erythema. Okay. So depigmentation is seen at least after 4 weeks of the exposure, or after 40 gray after the exposure. Okay. So radiation induced carcinomas is something stochastic. It is not deterministic. Okay. The radiation caries is caused by irradiation of salivary glands, enamel and dentine, oral mucosa. So the radiation doesn't cause any effects to the enamel and dentine. So these are all the calcified tissues. So there the effects of the radiation is not seen, whereas it affects the acina cells to actually cause atrophy, and this atrophy of the acina cells will actually lead to the destruction of the salivary glands, and the parotid will actually get the effects in almost at a dosage of 25 gray, whereas the submandibular gland can withstand up to 39 gray. Okay. Whereas the oral mucosa consists of different layers of cells, that is the stratum basale, the stratum spinosum, granulosum, and the corneum. And so the differentiation may actually disturb, causing ulceration. Okay. So the radiation caries is actually caused by irradiation of the salivary glands. The first complication after radiotherapy in the oral mucosa, or with respect to these options, we can think as first complication after radiotherapy is mucositis. Okay. So candidiasis is maybe on the later aspect. Alopecia, that is loss of hair. The loss of hair in case of radiation and chemotherapy, it is called as epilation, epilation, epilation. And xerostomia is subjective dryness of the oral mucosa. Okay, it is actually different to each person. Adu vandu perisa pain mari you can't measure it, xerostomia. Okay, so the first complication after radiotherapy is mucositis. So salivary glands, we have seen that it affects the salivary glands, and it may lead to actually reduction in the saliva, and which in turn may cause radiation caries. The radiation caries are of 3 types. One is it affects the smooth surface. The second one is actually it affects the cervical aspects of the teeth, and in the type 3 type of radiation caries, it causes actually the amputation of the crown. Okay, amputation of leg, amputation of arms, எல்லாமே நம்ம கேள்விப்பட்டிருப்போம். அந்த மாதிரி அந்த crown aspect வந்து அப்படியே amputate பண்ண மாதிரி இருக்கும். So the type of caries which is seen after radiation therapy is called as the amputation caries. Okay, and what effect it can cause in the teeth or the teeth buds is that it can actually cause small teeth formation, or it may actually destroy the teeth bud as such, leading to and in the taste buds there will be loss of taste sensation, and the patient can actually reverse it in about 3 months. The loss of taste sensation is reversed in about 3 months. Okay, initially during the treatment there will be destruction of the taste buds and there will be alteration of the certain taste sensation, but later on the taste sensation will be normal. Okay, and in the bone it causes serious effects like the osteoradionecrosis, and in the musculature it causes atrophy of the muscle leading to reduced mouth opening. Okay, so these are all the effects of the radiotherapy in oral tissues in brief. So mucositis is the first side effect followed by radiation therapy. It is actually the inflammation of the mucous membrane, where initially it causes inflammatory changes. Later on the epithelial atrophy takes place, causing to ulceration, and once when the treatment is reversed, it is healed. The normal epithelium is healed. Okay, these are all the pictures which shows the various stages of mucositis. The complication of the irradiation of mouth may include all except accelerated caries activity, caries in unusual sites, accelerated periodontal disease, xerostomia. Though it causes caries due to reduction in the salivary flow, it doesn't alter the periodontal status of the patient. So here the option is C. Okay, since the question was except, so it is actually accelerated periodontal disease. The radiation affects the blood supply because of, okay, so as I told you, it may affect the bone causing osteoradionecrosis. So bone gets supply from the small arteries. Okay, so since these arteries are occluded, or it may cause end arthritis of small blood vessels causing osteoradionecrosis of the bone. Okay, so radiation affects the blood supply because of end arthritis of small blood vessels. It is not because of anemia or infection. Osteoradionecrosis is due to end arthritis, damage of periosteum, damage to lymphatics, all of the above. So it's only end arthritis. Okay, it is due to hypocellularity, hypovascularity, hypoxia, and in the recent days, there is one more theory which tells that there is osteoradionecrosis, is that the fibroatrophic theory. Okay, the fibroatrophy. Apart from hypocellularity, hypovascularity, and hypoxia, so radiation-induced caries occurs in 1 month, 3 months, 6 months, and 9 months. So initially after 1 month, as I told you, it will take almost 25 gray, or it is up to 35 gray to affect the major salivary glands. Okay, so this 25 gray or 30 gray is not achieved up to in the first month itself. So it may take almost 3 months to affect all the salivary glands and causes atrophy of the acina cells to cause the caries. So here the best option out of this is 3 months. Okay. So radiotherapy associated caries is due to irradiation of which part? Most probably tongue, maxillary sinus, parotid gland, and the lower jaw. It doesn't affect the tongue or the maxillary sinus or the lower jaw. It affects the parotid gland to cause the caries. Following acute radiation syndrome. Okay, severe hematopoietic symptoms are seen in which dose? So in the lockdown time, you must be aware of the LG issue, right? In Vizag, there was a accident which actually led to the acute radiation syndrome to so many people, and there were some of the other examples which I can narrate is the Chernobyl attack, the Bhopal gas issue, everything. Okay, so whatever is given as a treatment, if it exceeds the dose, it may actually cause very serious effects. Okay, so treatment கொடுக்கும்போது ஒரு கிரே 2 கிரே இந்த மாதிரி fraction பண்ணி cumulative கொடுக்கிறது எல்லாம் ஒட்டுக்கா ஒரே நாள்ல if the patient is getting subjected to that particular dose, it may cause serious symptoms. Okay, so that is called as acute radiation syndrome. Okay, so it is a deterministic effect of the radiation which affects the systems. Okay, so following acute radiation syndrome, severe hematopoietic symptoms are seen in which dose? 1 to 2 gray, 2 to 4, 4 to 7, 7 to 50. So it's actually 4 to 7. Okay, so the example is certain radiation accidents. So in 1 to 2 gray, initial prodromal symptoms of the skin is seen. 2 to 4, mild hematopoietic. The question was severe hematopoietic. So that is 4 to 7, and gastrointestinal is 7 to 15. And when it exceeds 50, there will be severe cardiovascular and central nervous system symptoms causing collapse. In radiobiology, the latent period represents the period of time between cell rest and cell mitosis, the first and last dose in radiation therapy, film exposure and image development, no, the radiation exposure and onset of symptoms. Okay, latent அப்படினாலே வந்து ஒரு time period between the exposure and symptoms. Always we use this term in viral infection also. What is latent period? The exposure, the entry of the microorganism in that particular person, and you get the first symptom. அதுதான் வந்து அங்க latent period in case of infectivity. Okay, here in case of radiobiology, there is this latent period is defined as the period of time between the radiation exposure and onset of symptoms. The most sensitive phase in cell division is, we know that the DNA is the most very affected part of the cell, and adaliyum in the phase vandu very important is G1, G2, S, or none of the above. G1 is something where the cell is getting for the synthesis of DNA. The next is synthesis phase, that is S phase. The next is G2 phase, meiotic phase. Okay, so the very sensitive is the G2 phase. Okay, after the synthesis of DNA is the phase which is very sensitive for radiation. Okay, next is intraoral films and techniques. So the base of the X-ray film is composed of polyester, gelatin, nylon, bromide. Base அப்படிங்கிறது நம்ம film பிடிக்கிறோம் இல்லையா, அது வந்து what is it made up of? Okay, polyester, gelatin, nylon, bromide. It is made up of polyester. Okay, அதுக்கு மேல இருக்கிறது தான் வந்து emulsion. The predominant crystals in IOPA film. So here the question is the predominant crystals in the IOPA film with respect to the emulsion part of the film is potassium bromide, potassium iodide, silver bromide, silver iodide. So the option is silver bromide. So these are all some of the direct questions. Okay. So what is the function of lead foil in the film packet? Moisture prevention, to give rigidity, absorb backscatter radiation, protection against fluorescence. Fluorescence doesn't have anything with the IOPA film. Moisture, rigidity is the function of the base. Okay. Moisture protection is again a black cover which surrounds the film. So the best option is to absorb the backscatter radiation. Okay. Diagnosis of incipient caries. Incipient அப்படிங்கிறது ரொம்ப early-ஆ இருக்கிற caries is routinely viewed with what speed film? So I told you the speed, the films are categorized based upon the size, based upon their use, and based upon the crystals present. Okay, tubular-ஆ இருக்கா இல்ல வந்து grainy, it depends upon the grains which is present in the film microscopically. It is divided into A, B, C, D, E, and F. So what we most commonly use is the E films, and the film laye pathina chinnada ezhudi irukum int. Okay, next time when you see an IOPA film, just see that there will be a small indication. Okay, so the diagnosis of incipient caries lesion is seen with the E film. So some of the options will be like, if it is an F film, don't confuse it with that. E film is the option. Okay. So this is how the film will be seen when you open the film. Double side, it will be covered with the black paper, which is the moisture protector, and the outer waterproof protector, and then followed by that is the black paper, then the film, then the lead is actually one to absorb the backscatter radiation. Okay. So this is the film base, the picture of the film base and the film emulsion with the crystals suspended, and these are all the dimensions. You can actually take a screenshot because the dimensions idella vandu ennikku maara poradhu kedaiyadhu. These are all some of the values. When you have time, you just note it down. And film holders, why I wanted to put this picture is that this film holder, the one which is seen here in the arrow, is called as the snap array. Okay, so snap array is a type of film holder which is used in taking an IOPA through the bisecting angle technique. Okay, so if there is a picture and if they ask a question, so this is called as the snap array. So what is the size of occlusal film? 24 into 40, 31 into 41, 57 into 76, 33 into 35. So some dimension which is more is the option for the occlusal film. Yes, it is 57 into 76, which is 3 times greater than that of the normal size 2 film which you use. Okay. So this again is a picture showing the various dimensions of the films which we use. Size 0 is a one which is used to take IOPA of the that is speed of films. Size 1 for anterior adult. Size 2 is one most commonly we use. And bite-wing films are one which is used exclusively to see the proximal caries. Okay. So that is again divided into anterior adult, posterior adult, child, and anterior child. In the occlusal film, this is the dimension 57 into 76 millimeters. This occlusal film technique is also called as the cross-sectional technique. Okay. So based upon the speed, it is divided into A, B, C, D, and E films. So these are all some of the important measurements or the extraoral films which we used. The 5 into 7 inches films are used to take the TMJ views, temporomandibular joint views, and lateral oblique. Okay. And 8 into 10 films are used to take the skull view. அதாவது ஒரு பார்ட் TMJ அதுக்கப்புறம் வந்து lateral oblique. So these are all some of the views which you take only a part of the maxillofacial region, whereas 8 into 10 inches film is used to take skull views. Okay. 6 by 12 and 5 by 12 is used for panoramic views. Okay. So this extraoral films are used along with the intensifying screens to minimize the radiation exposure. They are not used separately as the IOPA films. They are used along with the intensifying screens. So questions pertaining to the techniques. So when the distance from the X-ray source அப்படிங்கிறது IOPA machine la and the cathode anode, those it's called as the X-ray source. So when the distance from the X-ray source is doubled, the beam intensity is increased twofold, increased fourfold, reduces one fourth, or reduces one half. Okay. So here the option is D. Okay. So this is given by this explanation. So if you actually increase the distance, the intensity will be reduced. Okay. Inverse square law. And this is also one important. If the focal spot is very large, then the shadow or the penumbra of the resultant image will be more. So all this you will be getting as a statement questions. So larger the focal spot, larger the penumbra or the shadow. Smaller the focal spot, again it is the smaller the penumbra. But if the focal spot is pointed or if it is very effective, then the image will have a very good resolution, or if the outline of the image will be very clearly defined. So that is why the focal spot is actually effective. We keep it as a effective or a point focal spot. Okay. A long cone or a 16 inches cone is used in a paralleling technique to reduce secondary radiation, to reduce image magnification, to reduce exposure time, to reduce the image resolution. So long cone is 16 inches cone which is used in paralleling technique. Paralleling technique அப்படிங்கிறது நார்மலா நம்ம எடுக்கிறது கிடையாது. We use it with a separate device. So that is used to reduce secondary radiation, image magnification, exposure time, or image resolution. The option is it is used to reduce image magnification. Okay. So why we use paralleling radiograph technique is that it is the one where we can actually repeat or take the radiograph again and again to see some prognosis. Okay. So if you do a treatment, that is if a patient is treated for a bone loss, and what technique is used to what is the best technique to see the review அப்படின்னு கேட்டாங்கன்னா, whether it is bisecting or paralleling technique, it is actually paralleling technique. ஏன்னா நம்ம எடுக்கிற செகண்ட் ரேடியோகிராஃபும் ஒரே ஆங்குலேஷனை வச்சு எடுத்தாதான் we'll be able to see the prognosis of the treatment which we have done. Okay. So அந்த prognosis பார்க்கிறதுக்கு we should actually get images with less errors, less magnification, or less distortion. So we use this paralleling technique to reduce certain projection errors. Okay. The two techniques are the paralleling or the right angle or the long cone technique. The bisecting angle technique is also called as the short cone technique. Okay. So if the position indicating device is about 8 inches, then the resultant image will have so much of magnification than the object. And if it is almost 16 inches, that is in the distance romba adhigamachina, the resultant image magnification will be less compared to that of the previous technique. So the paralleling technique is more superior than that of the bisecting angle technique. These are all the rings. Okay, so these are all the rings which is used in paralleling technique. Don't get confused. The snap array is one which is used in bisecting technique. So these rings are used in paralleling techniques. Okay, so in this holder the IOPAs will be placed. So this is for the anterior tooth, the vertically placed, and this is for the posterior teeth, horizontally placed. So the bisecting angle techniques works in which principle? It is also called as Czanski's rule of isometry. Okay, so here if two triangles share the same side, then it is called as the rule of isometry, and this principle is the actual principle behind the bisecting angle technique, and what we normally take is the bisecting angle technique with different vertical angulations, and horizontal angulation is 0. Okay, vertical angulation mattumna maru, horizontal angulation will be 0. Okay, so the positive angulation for the maxilla, the negative angulation for the mandibular teeth. So there the film holders was there, but here you need not have any film holders. Okay, so this is a picture which depicts the IOPA which is taken in a maxillary central incisor. Okay, by means of bisecting angle technique. The radiographic shadow that obliterates the apices of the maxillary molar teeth when using bisecting angle technique for IOPA is. So when you take a IOPA by means of a bisecting angle technique, what is the shadow which obliterates the maxillary molar teeth? Okay, so generally when you take a molar teeth, above that there will be floor of the maxillary sinus, and one more structure will be hindering that. So what is that? Orbital process of malar bone, zygoma and zygomatic process of maxilla, zygomatic arch. So it's actually zygoma and zygomatic process of the maxilla. Okay, so this is the explanation slide for the question. So the upper one, the upper dotted line is the projection while taking a bisecting angle. Paralleling is one where you keep the film and the source very parallel. Okay, filmu source வந்து parallel இருக்கிறங்காட்டி this part of the zygomatic arch will not get superimposed in the IOPA. But in the bisecting angle technique, when the beam is directed towards the zygomatic arch, a portion of the zygomatic arch will get superimposed over the root of the maxillary molars. Okay, when the vertical angulation is more in bisecting angle technique, what happens to the resultant image? Whether it will get elongated, shortened, penumbra appears, cone cut is seen. Okay, so these are all, yes, it is actually shortened. Okay, so imagine taking a selfie in your phone. Okay, இப்போ செல்ஃபி எடுக்கும்போது நம்ம ரொம்ப குண்டா தெரிஞ்சோம்னா ஒரு angulation which we take it from the topmost angle, right? We don't take it directly near our face. We'll just angulate it in such a way that we look very thin. So that is the concept behind. And exam ku easy ah nyabagam vechukonu appdi nenichingina, if the vertical angulation is more, then the image will be shortened. If the vertical angulation is less, then the image will be more. Okay, for exam point of view also you can remember in this way, and practically if you see while taking pictures, when you angulate and take certain images, it will actually look thin than that of the original image. That is if the angulation is more shortened. Okay, so these are all some of the explanatory pictures for the questions. Again, you can take a screenshot. Shortening is due to more vertical angulation, and elongation is due to less vertical angulation. Statement questions. The paralleling technique uses long cone to acquire greater vertical angulation. No, it doesn't have anything to do with the vertical angulation. Greater object to film distance, greater developing time, again no. Greater anode to film distance. So it's actually greater object to film distance and greater anode to film distance. Okay, so vertical angulation doesn't have anything to do with the paralleling technique, and also there is no factors which affect the developing time and the technique. So it's only the object to film distance and anode to film distance. Again, this is a summary which can compare actually the short cone and the long cone techniques. Okay, some of the questions I have given with the picture explanations, and also you can take a screenshot. Yes. So which of the following has greater bone density, and which is a very ideal region to place in conventional implants, the other way. Okay. So which has the greatest bone density? The posterior mandible, the posterior maxilla, anterior mandible, so it's actually the anterior mandible. So the grids which is used in radiography is to remove secondary radiation, filter the radiation, remove scattered radiation, none of the above. So I told you that grids are used in extraoral radiography to actually remove the scattered radiation. Okay, so when you use grid, the exposure will be more, whereas the image will be very good. So this is a picture which shows the use of grids. Okay. So filmukku munnadiye vandu grid place panniduvanga, and it is a one which actually removes the scattered radiation, and more amount of X-ray exposure is needed while taking images using grids. Okay. And the types of grids are focus grids and non-focus grids, stationary and moving grids. In the type of grids vandu enga use பண்ணுவாங்க அப்படிங்கறது மட்டும் you just make a note of it. Okay. Stationary grid, as the name suggests, that it is present between the object and the film, and these are all again the type of stationary grids. Okay, so you may get a very easy question like which among the grids are not stationary grids abdin sollitu. So just make a note of it: the linear, focused, pseudo focused, and the crossed grids. Whereas the Potter Bucky grid or the moving grid is the one which is not stationary. Okay, the only grid which is not stationary is the moving grid or Potter Bucky grid. Screen film differs from the non-screen films in such a way that screen அப்படிங்கிறது intensifying screens ஓட. In other way, it is actually the extraoral films. Okay, screen films or intensifying screen ulla films or extraoral films differs from non-screen films in that they are sensitive to light than X-rays. They are more sensitive to X-rays than light. Usually it is seen in intraoral technique, does not need intensifying screens. Okay, so they are very sensitive to light than X-rays. Okay, what makes it very sensitive to light is that the presence of certain layers. Okay, so these are some of the layers which can actually make the photon number increase. So this is the picture which gives the explanation for that. So when this is a one X-ray beam, and after this X-ray beam passing through the intensifying screen, the number is increased into 3, which shows that it is very sensitive. Okay, and then it hits on the film, and again it causes certain fluorescence which emits from that particular film, and then it is absorbed back in the screen. Okay, so the substances or the materials which is used as the in the intensifying screens were the calcium tungstate, zinc sulfide, zinc cadmium sulfate, barium lead sulfate, and terbium activated gadolinium oxysulfate, and thallium activated lanthanum oxybromide. So the recent days, the last two materials are most commonly used, but in the previous era, the calcium tungstate was used. Okay, so nowadays they don't use calcium tungstate due to certain disadvantages, which we'll see in the coming up MCQs. So the phosphors which is used in the intensifying screen are as follows. So these are all the materials which are used as the phosphors in the intensifying screens. So compared to calcium tungstate, the rare earth screen decreases the patient exposure by 15%, 35%, 55%, or 75%. Okay, so that's why I told you. So compared to calcium tungstate, the rare earth screen, the terbium activated, the niobium activated, all those are the rare earth screen elements which actually decreases the patient exposure by nearly 50% when compared to calcium tungstate. So that is why calcium tungstate is not used nowadays. Bite-wing radiographs are taken to look for narrowing of periodontal space, proximal caries, resorption of root, internal resorption. So these are exclusive techniques which is used only for the proximal caries. Okay. So here in the bite-wing radiograph, we use a bite block where the patient will bite this bite block and only the proximal surfaces of the tooth will be seen and not the periapical surfaces. Apex ku mela irukkiradhu periapical, apical surfaces theriyadhu, only the proximal surfaces are seen. Okay. The next is the occlusal radiography, which is also called a sandwich radiography. And with respect to this occlusal radiography topic, I've given more of pictures because the picture questions which was asked mostly is the questions pertaining to the occlusal radiography along with the lesions. Okay, so as I show the pictures, you can just take a screenshot of that. Okay, so the other name is sandwich technique. So this is the film which is used, and this is the raised dot which is opposite to the tube head. This is the raised dot opposite to the tube head, and it is taken in the maxillary and the mandibular arches, and depending upon the lesion we can actually place it in the central part or in the lateral part or in the anterior part. Okay, bilaterala ஏதாவது ஒரு லீஷன் இருக்கு, ரெண்டு பக்கமே ஜால இருக்கு அப்படின்னா சென்டரா வைக்கலாம். ஒரு பக்கம் மட்டும் இருக்கு அப்படின்னா லேட்டரலா வைக்கலாம். ஆன்டீரியர்ல மட்டும் இருக்கு, முன்னாடி மட்டும் இருக்குன்னா ஆன்டீரியர்ல வைக்கலாம். ஓகே, எந்த இடத்துல வைக்கிறோமோ அதை பேஸ் பண்ணி we give the name for it. Simple. Yes, all this is picture based images. So this is the occlusal radiography of the maxillary arch showing the impacted canine. Okay, so the question may be like which tooth is impacted or which is the view. So this is the maxillary cross sectional. Cross sectional அப்படினா ரெண்டு பக்கமுமே தெரியும். Got it? So this is the mandibular occlusal radiography showing the impacted canine. Okay, and this is the maxillary occlusal radiography showing the impacted canine, and this radiolucency which is seen in the molar region is called as the it is actually nasolacrimal. Okay, so this is a normal and anatomic variant. So here you can see the this prominent part is the genial tubercle, and this is the a radiopaque structure which is seen in a cross-sectional mandibular occlusal radiography, which is the salivary stone or the salivary calculi. Okay, so this is the salivary calculi of the submandibular gland. And for this exposure, you need to actually reduce the exposure to 1/3. நம்ம normally எடுக்கிற exposure விட கம்மியா எடுக்கணும். The reason is பல்லு மாதிரி இந்த கால்குலை வந்து அவ்வளோ கால்சிஃபைடா இருக்காது, அவ்வளோ கால்சியம் ஸ்ட்ரக்சர்ஸ் வந்து இருக்காது. பிகாஸ் இட் இஸ் ஜஸ்ட் அண்ட் மேட்ரிக்ஸ், ஒரு மேட்ரிக்ஸ் மாதிரி தான் இருக்கும். ஸோ அந்த அளவுக்கு நம்ம ரேடியேஷன் எக்ஸ்போஷர் கொடுத்தோம்னா இது ஒரு வேளை விழாம போயிடும். ஸோ வி கேன் ஆக்சுவலி ரெடியூஸ் த எக்ஸ்போஷர் டு 1/2 or 1/3. Okay, and also it is used to evaluate the extent of the lesion. So in this radiograph you can actually see a lesion, an artifact due to a foreign due to the removal of due to not removing the foreign objects, and this is a cyst. So when it comes to cyst, the most common cyst abdinale dentigerous ku pogadinga, it is actually a radicular cyst. The common question adikadi kepanga, the most common cyst is the radicular cyst, the most common ulcer is the traumatic ulcer, and the most common odontogenic tumor is actually odonto. So these are all some of the questions, very easy direct questions. Okay, so here you can see a well corticated radiolucent, unilocular radiolucent area at the periapex of 1, 1 and 1, 2, most likely to be the radicular cyst. And this is the lateral. So this is the lateral occlusal radiograph, which shows teeth and also some of the fillings. And this intersection of the two lines is called as the Y line of Ennis. Y line of Ennis. ENNIS அப்படின்னு சில புக்ஸ்ல கொடுத்திருப்பாங்க. YENNIS னு கொடுத்திருக்காங்க. So it is Y line of Ennis caused by intersection of floor of the maxillary sinus and floor of the nasal fossa. Okay, so this is the lateral maxillary occlusal projection. So some of the pathologies where you can see is the peripheral ossifying fibroma. Okay, so periphery it is made up of soft tissues with some calcifications, with some calcified specks. So this is actually peripheral. Peripheral na bone oda illama velila soft tissue la or enlargement mari theriyudhu, and some ossifications or calcified spikes is seen inside that particular region. So that is peripheral ossifying fibroma. Okay, so this peripheral ossifying fibroma doesn't occur as such. Okay, first pyogenic granuloma mari agum, adukapra konja naal kalichu ஒரு calcifications உள்ள இருக்கும். ரொம்ப chronic-ஆன ஒரு stage போகும்போது it becomes as peripheral ossifying fibroma. Okay, it's actually a sequelae of the disease progression. So this shows cortical expansion. Okay, so this is a lesion which is seen in the posterior mandible with dislodgement, with alteration of the tooth movement, and the cortex is intact, but there is expansion. Okay, there is expansion, most likely to be ameloblastoma. So here you can see a lateral occlusal radiography which shows difference in the density of the bone. ஒரே மாதிரி trabecular pattern இல்லாம ஒரு டிஃபரன்ஸான ஒரு pattern இருக்கு, but there is no demarcation. ஒரு demarcation இல்லாம அப்படியே போனோட அப்படியே கண்டினியூஸா இருக்கு. Okay, so this is more likely to be fibrous dysplasia. Fibrous dysplasia is a type of fibro-osseous lesion which is seen in younger individuals, and most commonly it affects the maxilla, and the lesion is in such a way that the bony component is replaced by fibrous tissue, and in the radiograph it appears as a cotton wool appearance or finger like pattern like appearance, ground glass appearance. Okay, it has so much of appearances, but there will be no demarcation with the normal bone and the altered bone. Demarcation illama apdiye ottuka irukum. Okay, next is a large radiolucency which is seen in the central aspect of the maxilla, very large, but the teeth are vital. Okay, so if the question is, if you see a large radiolucency in the central aspect of the maxilla in an occlusal radiography with a teeth vital, and if the option is nasopalatine duct cyst, then that is the correct answer. Okay, either way, teeth vitala illama, if the question is like radiolucency in the central aspect, then it is most likely to be radicular cyst. Okay, yes. Osteosarcoma, you must be knowing the appearance is very thoroughly. Sun ray appearance, Codman's triangle. But when I show as a picture, you can easily remember. So this is the sun ray appearance. This is one form of periosteal reaction of the bone to the disease. And this is the Codman's triangle, which shows that the malignancy is very easily progressing. Okay. And this is a type of granuloma, that is central giant cell granuloma, which appears as a multilocular radiolucencies. Multilocular radiolucency அப்படிங்கிறது it may appear as a honeycomb type, soap bubble type, or tennis racket type. Okay, tennis racket அப்படிங்கிறது உள்ள இருக்கிற அந்த குட்டி குட்டி loculations எல்லாம் ரொம்ப குட்டியா இருந்துச்சுன்னா tennis racket, அதை விட கொஞ்சம் பெருசா இருந்துச்சுன்னா it is honeycomb, இன்னுமே பெருசா இருந்துச்சுன்னா it is soap bubble. Okay, so most common lesions are, there are many lesions. You can just remember like ameloblastoma, your myxoma, your central giant cell granuloma. Okay, so when it comes as your statement question, it will be easy, but when there is a picture question, again you should think and then answer. So these are all some of the prominences, bony prominences seen in the maxillary and the mandibular cross-sectional, this is nothing but exostosis. Okay. So this is the use of the cross-sectional or the occlusal radiography to see different types of lesions. Yes. So most of the picture-based direct questions are covered. So to localize a supernumerary teeth or an impacted teeth and to determine where the teeth is, buccala irukka illa palate la irukka, supernumerary teeth irukku நம்ம OPG la கண்டுபிடிச்சிருவோம். ஆனா எப்படி இருக்குன்னு தெரியணும் இல்லையா? Then only the surgeon can actually approach for a surgery. So what are all the views you take it? A periodical occlusal view, an occlusal high angle, OPG, 2 or more periapical view at different angle, and then occlusal. Okay, so the option is 2 or more periapical at different angle and then occlusal. 2 or more periapical அப்படிங்கறப்போ slob rule வந்துரும், whether it is lingually placed or it is buccal அப்படிங்கறது தெரியும். And along with the occlusal, it is very clear that where the tooth or the where the impacted or the supernumerary teeth is. Okay, so this is a two-dimensional. So here it shows that it is on the lingual aspect. The next questions is with related to the OPG. So this is the OPG machine with the control panel and the sensor. And the principle, I'll just make it quick. So this is the X-ray source, and this is the detector or the sensor, and the side of exposure which is first captured in the sensor is your, when it is through from the right side, the side which is captured first is your left side. Okay, and then the machine will turn around the patient to get the image of the entire jaw and the associated structures. Okay, so the real image, double image, and the ghost images. So these three terms you need to know. The structures which is seen, real images, and the structures which is seen in the midline is called as the double images. The structures which is seen away from the focal trough is called as the ghost images. Okay, so the ghost images most commonly seen is your hyoid bone or the spine. Okay, apart from that, if the patient is wearing any jewels, that also appears in the OPG as ghost images. So these are all the soft tissue structures which is seen. That is the tongue, the soft palate, and the uvula, the lip line, and the ear, a part of the ear. And the air spaces which is seen in the OPG is the palatoglossal air space, which continues as the nasopharyngeal air space and the glossopharyngeal air space. Okay, the one which is seen above is the palatoglossal. Some radiolucency you can see above the ash, that is called as the palatoglossal air space, and which continues as a nasopharyngeal air space, and which further continues inferiorly as glossopharyngeal air space. Okay, so the common errors in the OPG encountered are the patient preparation errors. If the patient is not asked to stand properly, then there will be exaggerated or the smile lines will be seen. And if the patient is not prepared properly, that is if the ornaments are not removed, or if the patient is asked to stand with the thyroid collar, then a radiolucency or the radio opacity will be seen in the image. And if the cassette is not positioned properly, then the entire jaws will not be captured properly. Okay, so this is the picture. So this is the picture which shows the ghost image. Here you can see a radio opacity, and this ghost images are seen on the opposite side, slightly superior, and it will be distorted. Okay, so you may get a question like, how does the ghost image appear? Inferior, superior, distorted, or same as that of the opposite side? It is actually slightly superior to the actual side, and it will be distorted. Okay, and this is a artifact. This is an artifact due to the patient wearing the thyroid collar. Okay, thyroid collars are not indicated for taking extraoral radiography, as it may obscure the structures seen in the OPG. Okay, so this is a picture which shows the error when the patient is wearing a thyroid collar. So some of the positioning errors And what are all the manifestations which you see on the panoramic images? It is given here. You can just take a screenshot. What if the patient's chin is tipped high, low, and the patient is placed forward in the bite block or positioned backward? And what if the patient's tongue is not properly rested about the palate, and if the head is tilted to one side, the opposite side? Okay, so what are all the manifestations which you get it in the panoramic radiograph? It is here. Yes. So the advantage of OPG is broad coverage of facial bone and teeth, less patient exposure, less patient radiation dose, used in patients who can't open their mouth, all of the above. So the option is all of the above. So it covers entirely the facial bone in patients who can't open the mouth. So the main disadvantage of OPG is more radiation exposure, inconvenience for the patient, difficulty in interpreting the image, inability to record the fine details. The fine details can't be recorded, especially the midline structures. The size of the image layer is affected by velocity of receptor, alignment of X-ray beam, collimator width, all of the above. It's actually all of the above. And apart from that, there are some of the factors which affects the image layer. That is the arc path, alignment of X-ray beam, and the collimator width. The collimator used here is the tubular collimator. So which of the following opaque soft tissue structures may be identified in the OPG? Okay. So as I told you in the previous picture, I gave you some of the line diagrams which shows the soft tissue which is seen in the OPG. So here the option is all of the above. In OPG, smile appearance. Okay, the smile appearance of structures appears when the patient chin is tilted downwards. Okay, if it is if the patient is too anterior to the trough, then the structures of the midline will not be seen properly. If it is posterior to the focal trough, it will be shortened. If the patient head is tilted downwards, it will be like a patient smiling image. If it is tilted upwards, then it's reverse smiling. Okay. The ability of the image receptor to capture a range of X-ray exposure is resolution, latitude, sensitivity, spatial resolution. Okay, to capture the range of X-ray exposure is some term which is used to tell the properties or the image characteristics of the film. Okay, so this is actually latitude. So these are all some of the terms which is used to compare the image quality, that is density, brightness, latitude, dynamic range, contrast, and contrast resolution. And what I've given in the left side is all based upon the terms which is used for telling the characteristics of the film image, and what is given on the right side is based upon the characteristics of the digital image. Okay, density அப்படின்னு நீங்க சொல்றதெல்லாம் அங்க brightnessனு சொல்லுவோம், contrast அப்படின்னு சொல்றதெல்லாம் அங்க contrast resolutionனு சொல்லுவோம். Okay, just take it down. So resolution is something where you can actually differentiate between two smaller objects that are closer together. Say for example, your dentine and your enamel. If you're able to distinguish between the dentine and the enamel, then the image is of good resolution. Okay, and the sharpness is the ability to define the boundaries of the structures. Okay, so the capacity of the digital imaging technique to distinguish fine detail is spatial resolution. The digital image in computerized radiography is made up of, so it is made up of pixels, CCD, CMOS, and silver halide crystals. So here the option is it is made up of pixels. Okay, CCD, CMOS are different types of sensors, that is the charge coupled device and complementary metal oxide semiconductors, photostimulable phosphor plates, and flat panel detectors. So these are all some of the digital detectors which is used to actually capture the image, take the signals to the computer, and then we get the resultant image on the monitor or the film. Okay, CCD, the image will be carried by means of bucket brigade fashion. Okay, So next question is, CCD was introduced in the year 2006, 1987, 1886, 1786. So that was a recent invention. So the option is B, 1987. Okay. So as I told you, in CCD, so this mechanism also you can take a screenshot. Okay. So here the signals are taken by means of charged packets in a bucket brigade fashion. அதாவது ஒரு சார்ஜ் வந்துட்டு அப்படியே வந்து இன்னொன்னு in the form of bucket brigade fashion, whereas in CMOS each different type of signals are carried separately as a small voltage. Okay, so that is by means of a frame grabber. Okay, so I think you have taken a screenshot of this also. Whereas the flat panel detectors are one which is used in CBCT and your higher images. So when you get a question like which type of sensors are used in the CBCT, it is actually the flat panel detectors. It is not CCD or CMOS. Okay, it is only the flat panel detectors. So all are true for the radiovisuography, except it reduces patient exposure by 80%. It produces finer details than silver halide, produces instant image, easy to store and retrieve, which is true, except it actually doesn't produce finer details. Edge enhancement effect is seen in zero radiography. Okay. So zero radiography, it is a type of radiography which was used in earlier days, and in that particular radiography, the edge enhancement effect is good. Okay, scintigraphy is one which is used in case of nuclear imaging or fusion imaging, and stereoscopy is a type of imaging where you take two different types of radiographs in two different angles. Okay, so that is called as the stereoscopy, and out of this, the edge enhancement effect is seen good in zero radiography. So the gamma camera in nuclear medicine is used for organ imaging, measuring the radioactivity, monitoring the surface contamination, and radiotherapy. Okay, so the gamma camera is a recent advances which is used in the nuclear medicine for measuring the radioactivity. Here the body itself becomes as an machine, and then it will emit certain rays, and this rays will be captured, and the resultant image will be obtained to see the radioactive effect of the particular organ. Okay, so initially you inject some of the radionuclides in the patient's body, and then this particular radionuclide will emit the gamma rays, and this gamma rays is captured by means of the Anger camera, and then this is multiplied by means of photo multiplier tube, and then the electronic output is stored in the computer for images. Okay, so these are all some of the different types of nucleides used commonly. In the bone and the salivary glands, the technetium pertechnetate is used. Thyroid, iodine is used. In tumors and inflammation, gallium-67 is used. In CSF, to read the CSF fluids, indium is used. And to capture the lung function, krypton is used. Okay, so each substance has affinity to one particular organ, and then it was studied. And so the different substances are used for different organs. Okay. So which one gives maximum radiation exposure to the patient? Chest X-ray, MRI, CT, bone scan. It is actually the bone scan. Okay. MRI is one which doesn't utilize any radiation exposure. It is only the radio frequency. Okay. The imaging technique that can detect brain function is angiography, MRI, stereoscopy, positron emission tomography. PET scan. Okay. PET is one which can detect the brain function. What all images which we see in the previous slides is called as the structural imaging. Structure அப்படின்னா ஒரு பர்டிகுலர் ஆர்கன் வந்து என்ன ஃபங்க்ஷன் பண்ணுதுன்னு தெரியாது. இது இருக்கா இல்லையா, பல்ல சொத்தை இருக்கா இல்லையான்னு கண்டுபிடிக்கிறதுக்கு மட்டும்தான் வந்து IUPA அல்லது அதர் டெக்னிக்ஸ் யூஸ் பண்ணிட்டு இருந்தாங்க. ஃபங்க்ஷனலி இஃப் இட் இஸ் குட் அப்படின்னு ஒரு இமேஜிங் டெக்னிக் அப்படின்னு இருந்துச்சு அப்படின்னா இட் இஸ் ஆக்சுவலி த பெட் ஸ்கேன். That is why it is called as the functional imaging. If the organ is properly functioning, the imaging technique which we used is the positron emission tomography. So the radioactive material which we use is here is the fluorodeoxyglucose. Okay, so the biologically active molecule which is used here is the fluorodeoxyglucose, which will be taken up by the tissues, and எங்கெங்கெல்லாம் நிறைய functions நடக்குதோ எங்கெங்கெல்லாம் நிறைய actions நடக்குதோ அதெல்லாம் அந்த இடத்துல எல்லாமே வந்து this FDG will be taken up, and then you will be getting the image to detect the cancer most commonly. The spread of metastasis most commonly it is detected by means of PET scan to see where the metastasis is actually taking place. Okay, and the resultant image will be in such a way that these are all some of the axial sections, and these are called the hot spots. Red color la irukkiradhu ellame vandu hot spots. Ingengella vandu metastasis irukku appdin sollittu kandupidipanga. Okay, CT scans have several advantages over the conventional, except. So what advantages it has over the conventional radiograph, which is except. So there is availability of larger amount of information with relatively little radiation exposure. This is actually wrong. It causes or it gives information with more amount of radiation exposure. Okay, MRI is best in viewing various tissues except fat, bone, pooled blood, muscle. Okay, MRI is best in viewing only the soft tissues, not the hard tissues. So the option is bone. So these are all the persons who have contributed for the usage of MRI. And this is based upon the fact that the body is made up of 75% water, and this when kept in a magnetic field, it will just give signals. The resultant signals is responsible for the diagnosis of various lesions. Okay, and T1 Wade image is one which is used to demonstrate the normal anatomy, and T2 Wade image is one which is used to tell the abnormality or the pathology. Okay, when it is T1 Wade it is normal, it is T2 Wade image அப்படினா abnormal என்னென்ன தெரியுதோ அதெல்லாம் பார்க்கிறதுக்கு தான் it is T2 Wade image is used. Okay, the contrast most commonly used in MRI is the gadolinium, and the contrast most commonly used in CT is your iodine based. So the MRI involves the use of radio frequency pulse. Contraindications for MRI include very ill patients requiring constant supervision, patients with cardio pacemakers, patients with multiple clips, splints or various monitoring wires, all of the above, or BNC. It's actually all of the above. Okay, the patients should not there should not be any claustrophobic, அதாவது உள்ள ஒரு closed compartment இருக்கிறதுக்கு பயந்துக்க கூடாது, whereas they should not always carry the metallic substances which is very attractive to the room. Okay, in CBCT, that is cone beam CT, the speed with which individual images are acquired is called as the frame rate. So this is a picture which shows the difference between the conventional and the cone beam CT. In conventional CT, you image each part of the each part of the body separately with one particular dose of radiation, whereas in cone beam CT, you image this particular area and then this will be reconstructed separately in the computer to get the image. So that is the main difference between the conventional and the cone beam CT. Okay, so these are all the main differences. In CBCT, the patient movement is not required, whereas the patient is continuously moved. And CBCT can be taken in a dental office, but conventional CT need a separate suit. Okay, the radiation exposure is very less in CBCT compared to that of the conventional CT. In CBCT, the raw digital data for reconstruction is obtained from. As I told you, in CBCT, the machine will revolve around the patient completely. அதாவது ஒரு சுத்து ஃபுல்லா சுத்திட்டு தான் வந்து ஒரு இமேஜ் எடுக்கும். So obviously it is 360 exposure per projections. Okay, which is false about CBCT. It can be used to replace conventional. No, never. It is a 3-dimensional imaging techniques. Yes, image is composed of voxels instead of pixels. It is a tomographic technique. So CBCT can never replace a conventional radiography. If you have any second opinion regarding the artifacts caused by CBCT, CT is the very good modality to see the lesion. Okay. So this classification of CBCT is based upon the field of view. Okay. எந்த அளவுக்கு நம்ம ஒரு ஸ்ட்ரக்சரை எந்த அளவுக்கு நம்ம ஒரு ஸ்ட்ரக்சரை வியூ பண்றோமோ அதை பேஸ் பண்ணி it is called as the field of view. Entire maxillofacial region is viewed here in this larger focus, and only the maxilla and the mandible and only a part of the mandible. Okay, so depending upon this, the field of view is varied in CBCT. What does the term DICOM mean? You transfer the images by means of various systems. அதாவது ஒரு போட்டோவா இருந்தா JPEG ஃபைல் அந்த மாதிரி சொல்றோம் இல்லையா? ஸோ அந்த மாதிரி மெடிக்கல் ரிலேட்டட் டேட்டா we transfer it to means by means of the DICOM file, which is called as the direct imaging and communication in medicine. Okay, so that is called as direct imaging and communication in medicine. Cone beam related artifacts are due to undersampling, oversampling, poor calibration, metallic objects. It is always undersampling. Okay. MIP in CBCT stands for maximum intensity projection. Which of the following is false regarding ultrasound? Ultrasound is one where using ultra frequency sound waves, the lesion is examined, or it is told whether it is a cystic or a fluid filled or an empty lesion. Okay. CT, CBCT, X-rays, idellatukum or a particular substance, and that is X-rays where ionizing radiation was used. MRI, it is radio frequency pulse. Ultrasound, it is ultra frequency sound, which is used to diagnose a particular lesion. Interpretation is possible only during examination. No radiation, not good for soft tissues, inexpensive. It is actually good for soft tissues. Okay, especially in the head and neck region, to see any lesion with respect to the salivary glands, ultrasound is a very good modality. Fusion imaging is actually a combination of CT and PET or CT or SPECT. So it is actually a functional imaging. Okay. So some questions from extraoral radiography. Let's see. The best view for visualizing zygomatic arches is jug handle view. Okay, correct one. So it's a modification of submental vertex view where the exposure is 1/3 to see especially the fracture of the zygomatic arch. So these are all the most commonly used views in the maxillofacial imaging, and you may get a question by changing just the names. Okay, Cadwell projection, Elena Granger projection. அப்படிங்கிறது வேற வேற பேர் சொல்லி வந்து you will be getting direct questions. So what are all the different views to see different structures? I've just given. You can just take a screenshot of this. And when it comes to base of the skull, the only view to see the base of the skull is submental vertex projection, and the structures or the views which is used to see the radiography of the mandible are lateral oblique and rotated PA mandible. And for the temporomandibular joints, please take it down. The transcranial, the transpharyngeal with the other names, the transorbital with the other names. Okay, so these are all the projection names which is given to see the temporomandibular joints in a different way. That is either the head of the condyle, the medial aspect, the poles is seen. Which is true for lateral skull projection? The image receptor is positioned parallel to the mid-sagittal plane. The patient is towards the left side of the image receptor. The central beam is perpendicular to mid-sagittal plane, all of the above. So it's all of the above. Okay. So the image is parallel to the sagittal plane. So the central ray is perpendicular. So it is mainly used to, the skull view is mainly used to see certain systemic disorder alterations. The best view for viewing the maxillary sinus is lateral oblique maxilla, Tone's view, lateral skull, Waters view. It is actually Waters view. it is directed at an angulation of 37 degree, and if the patient is asked and if the patient's mouth is opened, what are the sinuses which can be seen? It is actually the sphenoid sinus. So this is the frontal sinus, this is the maxillary air sinus, this is the ethmoid sinus, and if the patient's mouth is open, you will be able to see the sphenoid sinus also. Ankylosis, or the union of the TMJ along the Attica surface, is best viewed with lateral oblique, true lateral, transcranial PA view. It's transcranial. Okay. For detection of herniation and perforation of the TMJ disc. TMJ disc is actually a soft tissue, and that herniation and perforation is best viewed by means of CT, MRI, orthography, transcranial. It's actually MRI. The radiographic view to be avoided in patients with cervical problem. Cervical problem na neck problem, ரொம்ப bend பண்ண முடியாம இருக்கிற பேஷண்ட்டுக்கு எந்த வியூ எடுக்க கூடாதுன்னு கேக்குறாங்க. It is actually SMV, submental vertex view, because in that view we'll be asking the patient to bend the neck entirely. If the patient is not able to bend it so much, we can actually take this view by asking the patient to lie down. Okay. So this is all the picture-based images showing. So there was one question telling that what is the structure of the mandible? A part of the mandible which is seen in the maxillary IOPA, it is actually the coronoid process. Okay. And what are the radiolucent structures which is seen in between the roots of the anteriors, and the patient doesn't have any history of fracture. Fracture la endha historyume illama fracture lines மாதிரி இருக்குல இந்த lines என்ன அப்படினு கேட்டிருந்தாங்க. It is actually nutrient canals. Okay. And what is this arrows which is seen below the apices of the maxillary molar? It is actually the submandibular gland fossa. The submandibular gland ange irukkranaல it will cause a depression in that bone, which is called as a submandibular gland fossa. And this is the picture of the scintigraphy, which will record your parotid and the submandibular along with the thyroid gland to see the uptake of the radionuclide. Okay, so these are all some of the images which is given the standard books like Burkitt, and most of the picture-based images are from the textbooks. Okay, so that's why I wanted you to see all these images. Scintigraphy edutha ipdi image irukum. Okay, and this is a picture showing a CBCT image with an altered panorama, 3D, coronal, sagittal, and axial. Okay, axial is something from the top to bottom. Coronal is from the anterior to posterior. முன்னாடில இருந்து பின்னாடி தெரியுற இமேஜஸா இருந்துச்சுன்னா coronal, ரைட்ல இருந்து லெஃப்டா இருந்துச்சுன்னா that is sagittal view. Okay. Sorry. The following are advantages of self-developing solutions except no darkroom facilities are required, image quality is superior, it is time saving, all of the above. Okay, so the image quality is superior. That is actually a false statement. The image quality will not be superior. Okay, so this is a picture showing the self-developing film where it will have the film here and the solutions will be here. So once you take this film, you can actually squeeze the solution so that both the developer and fixer will come in contact with the film, and then you will be able to process it without any darkroom setup. Okay. So these are all some of the terms which you need to know regarding the faulty radiograph. Herringbone pattern, which is seen in the IOPA film when the lead foil is placed facing the cone. Herringbone or tire track appearance. You can take a screenshot. And the other errors which is to be mentioned is the cervical burnout. Cervical burnout is actually seen in the IOPA as a caries due to improper horizontal angulation, and the other name of cervical burnout is adumbration. Okay. And next is phalangioma. Phalangioma is you will be able to see the patient's finger in the film. Patient வந்து அப்படியே ஃபிங்கரை ஹோல்ட் பண்ணிட்டு IOPA எக்ஸ்போஸ் பண்ணிட்டு இருந்துச்சு பண்ணாங்க அப்படின்னா you will be able to see the phalanges of the patient in that particular film. This is called as a phalangioma. Okay. The onion peel appearance is seen in osteosarcoma, Ewing sarcoma, chondrosarcoma, sickle cell anemia. It's actually Ewing sarcoma, and also in cases of osteomyelitis. In case of Gary's osteomyelitis, also you'll be able to see the onion peel appearance. A unilocular, a single locule radiorecency located near the mandibular angle inferior to the mandibular canal. Okay, the only radiorecency which is seen inferior to the mandibular canal is the Staphnase cyst due to depression of the submandibular gland. It is not actually a true cyst. Dead bone. Dead bone appears in the radiograph as radio opaque only. Okay, sequestrum. Loss of lamina dura and ground glass appearance is seen in Paget's disease, fibrous dysplasia, osteomalacia, and Keffi's disease. Fibrous dysplasia. Okay, and if the question is loss of lamina dura, ground glass, okay. So these are all some of the different patterns which are seen in the fibrous dysplasia. As I told you, the fingerprint pattern, the onion peel pattern, the dense bone pattern. Okay. So I think radiology part is done. So most of the questions I've discussed along with the image and also the explanatory part. So medicine, as Prasad sir would have already told that there will be some overlapping of the topics with medicine and surgery. So we'll also try to cover some of the clinical features and treatment part. And these are all the main topics which we are going to discuss here in the medicine part. Okay. So the first one is the ulcerative and the vesiculobullous lesion. So which of the following is a form of vasculitis? Behçet's syndrome, Cannon disease, Whitcock disease, Hex disease. Okay. Hex disease is also called as focal epithelial hyperplasia, where there will be some it is actually a dermatological disorder with some of the oral manifestations. It will have some papules on the palate, giving a suspicion of dentist dermatitis. Okay. And Cannon's disease is also called as the white spongy nevus. And Behçet's syndrome is actually a combination of certain conditions. And here the best option is Behçet's syndrome. So Behçet's syndrome is a combination of recurrent genital ulcerations and eye lesions along with the skin lesions, including erythema nodosum, papulopustular lesions, and acneiform nodules in patients who doesn't take any steroids. Okay, so all the symptoms is, if it is seen in a 1 year period along with the recurrent oral ulceration, then the patient is diagnosed to have Behçet's syndrome. Syndrome is a combination of symptoms, and when a pathology test is done, that is, if a 20 gauge needle is inserted into the skin of the patient for about 5 mm depth, a positive reaction is seen by means of the formation of papule or pustule. Okay, papule is nothing but a raised or a elevated appearances of the skin, and pustule is collection of pus, and this appearance is seen in about 48 hours, and the dimension will be 2 millimeters. Okay, so when all this is positive, then you did give a diagnosis of Behçet's syndrome. So I think I'll take a break for 2 minutes, and then the time is 12 o'clock. I'll again start by 12:05. Okay, we'll start. Recurring oral ulcer is seen in Behçet syndrome, lupus erythematosus, lichen planus, recurrent after stomatitis. Okay. So the option here is both A and D actually. So there are different types of ulcers. So the ulcer, it is actually both. The option is not D, it is actually both A and D. Okay. So we have seen now about the Behçet syndrome. So recurrent after stomatitis is a very commonly seen ulcer in the oral cavity. The most common type of ulcer which is seen in the oral cavity with recurrent history. Okay. The most common ulcer in the oral cavity abdina adukku vandu traumatic ulcer is the option. But when the word there is recurrent abdingra word irunduchina, the option is recurrent after stomatitis. Okay. After stomatitis is classified into major, minor and herpetiform. Minor abdingiradhukku if the dimension of the ulcer is less than 1 centimeter, it is called as minor after ulcer. If it is more than that, it is called as major. And if it is more like naraiya vandu or 100 ulcers, what they give in the textbook is nearly 50 ulcers in one particular lining mucosa, it is called as herpetiform. Herpes ulcers vandittu thaniya varadhu, naraiya group ah varadha vandu herpetiform. Okay. So the main occurrence of the herpes ulcers, the after ulcers is in the lining mucosa. Okay. Oral mucosa we நம்ம எப்படி டிவைட் பண்ணிருப்போம்னா keratinized, non-keratinized, specialized. Okay. Keratinized mucosa is your gingiva and the hard palate. Tongue is the specialized mucosa because it has taste buds adanala. And lining mucosa is all the other oral mucosa, that is your buccal mucosa, your labial mucosa, your floor of the mouth and the lateral surface of the tongue, soft palate. Idellame vandu lining mucosa. So the ulcer which is seen most commonly in the lining mucosa is the recurrent after stomatitis. Why I am telling this is because your herpes ulcers is seen in the keratinized mucosa. So when you get a question like which type of ulcer is seen in keratinized mucosa, then the best option is your herpetic gingivostomatitis. Okay. But when that recur, அதுவே திரும்ப வந்துச்சு அப்படின்னா அது வந்து herpes labialis லிப்ல வரும். Okay. So when you always read a question regarding to ulcer, ஈஸியா இருந்துச்சுனாலும் அந்த வேர்ட்ஸ் எல்லாம் ரொம்ப இம்பார்ட்டன்ட். அது ரெக்கரண்டா இல்ல காமனா இல்லனா வந்து திரும்ப வர மாதிரி இருக்கா. Okay. Everything is very important. So the recurrent oral ulcers abdina, it is recurrent after stomatitis and Behçet's disease. Okay. So what are all the ulcers which is seen in the acute multiple? Acute na konja naaliye adhe samayam nariya ulcers varudhu abdina, it is herpes simplex, varicella zoster, cytomegalo infections, Coxsackie infections. So the first four is with respect to your the first three is with respect to your herpes group of infections. Your herpes simplex, varicella zoster and cytomegalo is your herpes group of infection. Coxsackie is a different group. Coxsackie group of viruses. Okay, that is a different group. Necrotizing ulcerative gingivitis and periodontitis, which may be seen in the oral cavity and it may lead to certain conditions like noma. Okay, so that is necrotizing ulcerative gingivitis. And erythema multiforme, it is a separate entity and it is mostly associated with long-term herpes infections and also due to certain allergic reaction to certain drugs like very commonly taken drugs like paracetamol. Okay. And if the erythema multiforme is very severe, then it leads to Stevens-Johnson syndrome and toxic epidermal necrolysis. The other names is Lille's disease. Okay. So Stevens-Johnson syndrome and toxic epidermal necrolysis is the severe form of erythema multiforme. Some of the key points in erythema multiforme is target lesions. Okay. Recurrent ulcerations causing sloughing, severe sloughing of the oral mucosa with target lesions or bullseye type of lesions. Okay. And the next is oral hypersensitivity reaction. அதாவது எதுக்காவது அலர்ஜி, ஒரு புதுசா போட்ட பேஸ்ட்டுக்கோ இல்ல புதுசா ஒரு ஃபில்லிங் வச்சிருக்காங்க அந்த மாதிரி ஏதாவது hypersensitivity reactions which is very which is not very common. ஒரு சில பேருக்கு மட்டும் தான் அந்த மாதிரி hypersensitivity reactions இருக்கும். Okay, so these are all the multiple ulcers seen in the oral cavity. So some of the ulcers along with skin lesions are chronic multiple ulcers. Chronic இருக்கும் due to certain autoimmune conditions. Okay, due to certain autoimmune conditions, and this is chronic multiple ulcers. When it occurs in younger individuals, it is most likely to be pemphigus, and when it occurs in the older individuals, it is most likely to be pemphigoid. Along with that, linear IgA, epidermolysis bullosa, and chronic bullous disease of the childhood. Okay, so while discussing the MCQs, we'll see in detail, just know the names alone. So single ulcers, always traumatic, followed by granulomatous ulcers like your ulcer of the tuberculous or due to syphilitic ulcers, and ulcers due to fungus, that is mucormycosis, blastomycosis, and histoplasmosis. So what is the incubation period of primary herpes infection? So know that the herpes infection is primary and secondary. Okay, HHV 1 and 2, if it is primary, it appears in the oral cavity as herpetic gingival stomatitis, and later on this virus will have affinity towards one particular organ or organ la poi ukkandukom. Okay, and then later on, due to certain stress, and the person ku particular stress so illana vandu where edavadhu triggering factor vanduchna, again this virus will get reactivated and then it will cause certain lesion. So reactivation ஆயிட்டு வரும்போது it will come as herpes labialis. உதட்டுல வரும். ஸோ நீங்க ப்ராஸ்டோலேயே பார்டர் மோல்டிங் எல்லாம் பண்ணிட்டு ஒரு சில பேஷண்ட்ஸ்க்கு பார்த்தீங்கன்னா ஃபாலோட் பை பார்டர் மோல்டிங் ப்ரொசீஜர்ஸ் they'll have this herpes labialis. It is not mainly due to the procedure. Okay, the virus has get reactivated and then the lesions is present in the oral cavity. It is not your mistake. And some persons will get this lesion every season. அதாவது கோல்டு கிளைமேட் இருக்கும்போதோ இல்ல வந்து அவங்களுக்கு ஃபீவர் வரும்போதோ அந்த மாதிரி ஹெர்பஸ் லேபியாலிஸ் வரும். ஸோ தட் இஸ் வை இட் இஸ் கால்ட் அஸ் ஃபீவர் சோர்ஸ் ஆர் கோல்டு பிளிஸ்டர்ஸ். ஓகே, டோன்ட் கன்ஃபியூஸ் ஃபீவர் சோர்ஸ் கோல்டு பிளிஸ்டர்ஸ் வித் த கேங்கர் சோர்ஸ். கேங்கர் சோர்ஸ்ங்கிறது இன்னொரு என்டிட்டி. ஓகே, ஸோ fever sore and cold fever blisters and cold sores is actually herpes labialis. So the incubation period அப்படிங்கிறது அந்த வைரஸ் உள்ள போய் உங்களுக்கு சிம்டம் வர அந்த டைம் தான் incubation period. So it is almost 2 weeks. So this is a list which you need to know because some of the easy questions you will be able to answer. So as I told you, cold sores or fever blister is the other name of herpes labialis, which is seen exclusively in the lining mucosa, but primary lesion is seen in the keratinized mucosa. Okay, வாயில வர அல்சர்ஸ் எல்லாமே it is due to HHV1. Okay, in the lower half of the body it is due to HHV2. அவ்வளவுதான். அடுத்தது varicella zoster. varicella zoster வந்து சின்னப்போ வந்துச்சு, சின்ன வயசுல வந்துச்சுன்னா it is called as chicken pox. Okay, அதுவே திரும்ப அந்த பர்சனோட நர்வ்ஸ்ல வந்து ஆக்டிவேட் டார்மெண்டா இருந்து எந்த ஆக்டிவிட்டியுமே இல்லாம திரும்ப ஏதாவது இம்யூனோ காம்ப்ரமைஸ் ஸ்டேட்டுக்கு அந்த பேஷண்ட் போனாங்கன்னா lesions varum. That is called as shingles. Okay, so that time it will be disseminated அப்படின்னா எல்லா பக்கமும் அப்படியே ஒரே என்ன சொல்றது, அப்படியே நிறைய அல்சர்ஸ் வந்து அந்த பேஷண்ட்டுக்கு வரதான் வந்து disseminated form அப்படின்னு சொல்லுவோம். Okay, mainly it affects the C3, okay, cervical C3 third level, T5, L1, L2 and ophthalmic branch of the trigeminal nerve. ஸோ ட்ரைஜெமினல் நர்வ் பார்த்தீங்கன்னா ரெண்டு இடத்துல நம்ம பார்ப்போம். ஒன்று வந்து ட்ரைஜெமினல் நியூராலஜியால பார்ப்போம், அதுக்கப்புறம் ஷிங்கிள்ஸ்ல பார்ப்போம். ஸோ விச் பிரான்ச் ஆஃப் ட்ரைஜெமினல் நர்வ் இஸ் மோஸ்ட் காமன்லி அஃபெக்டட் இன் திஸ் zoster is it is ophthalmic, but when it comes to neuralgia it is actually maxillary. Okay, and the next one is cytomegalovirus. The fourth one is cytomegalovirus causing lesions. Next is Epstein-Barr virus. Epstein-Barr virus அப்படினாலே default you should know about 4 different infections. Infectious mononucleosis, oral hairy leukoplakia, Burkitt's lymphoma, nasopharyngeal carcinoma. Okay, when there is a question regarding Epstein-Barr virus, you should always remember this 4 options: infectious mononucleosis, oral hairy leukoplakia, nasopharyngeal carcinoma, Burkitt's lymphoma. Okay, Burkitt's lymphoma is also called as African jaw lymphoma. It is, the other name is doubling tumor. Okay, ஒரு particular group of people மட்டும் தான் அது affect பண்ணுச்சு. இன்னைக்கு ஒரு சைஸ் இருக்கு, இன்னைக்கு வந்து ஒரு 2 mm இருக்குன்னா அடுத்த நாள் அது அப்படியே 4 mm ஆயிடும். அதுக்கு நெக்ஸ்ட் டே அது அப்படியே டபுள் ஆயிடும். So that is why it is called as doubling tumor. Okay. The human herpes virus 6, 7 doesn't cause any lesions in the oral cavity, so we will not speak about it. HHV 8 abdina, it causes Kaposi's sarcoma. Kaposi's sarcoma is a tumor. It's an endothelial tumor which is commonly seen in HIV patients. So earlier days, the most common tumor which is seen in HIV patient abdina, it is Kaposi's sarcoma. But now, if you get to options like non-Hodgkin's lymphoma, then the better option is non-Hodgkin's lymphoma. Okay. So this is a picture showing herpes labialis lesions. Okay. இது வந்து crusting ஓட, அதாவது ஹீல் ஆயிட்டு இருக்கும்போது இப்படி இருக்கும், ரொம்ப ஆக்டிவா இருக்கும்போது இந்த மாதிரி இருக்கும். So histopathological features, like importantly, intranuclear inclusion bodies, or the presence of giant cells. It is seen in herpes simplex. Okay. So the main line of treatment for this is antiviral drugs. Acyclovir 400 mg 5 times a day for 5 days. Okay. When it comes to zoster, herpes zoster, it is actually acyclovir 800 mg 5 times a day. Okay. So the virus which causes herpes zoster is same as that which causes chickenpox. If you want the table to be taken a screenshot, I'll just give time. You can take a screenshot. Okay. And the question enna ketirundanga, the virus which causes zoster is same as that of chickenpox. Okay. Herpangina and measles, we'll be seeing some of the questions. We'll see. So zoster is very typically unilateral. The line pota madri one side of the division only will be affected. So here it has affected the maxillary division of the trigeminal nerve. So that is why the crusting or the lesions, it is seen only in the area supplied by the maxillary division of the trigeminal nerve. If it affects the ophthalmic division, it will cause blindness or scarring, or if it affects the mandibular division, the lesion will be seen in the lower lip and the lower gingiva. Okay. So here there's a picture which shows the patient is affected by the maxillary division of the trigeminal nerve. And one more complication is when it involves the geniculate ganglion, it is called as Ramsay-Hunt syndrome, where you will be having symptoms like Bell's palsy, vesicles seen in the external surface of the ear, and there will be loss of taste sensation in the anterior 2/3 of the tongue. Okay. And this is one viral lesion where you will be seeing resorption and exfoliation of the teeth when severely involved. Okay. And osteoradionecrosis is also seen in very immunocompromised patients, like in case of HIV. And one more important addressed complication of this entity is post-herpetic neuralgia. Okay. So post-herpetic neuralgia is most commonly seen in elderly patients due to the scarring of the nerve. It is very painful scenario where it is treated with gabapentin and 5% of lidocaine patch to reduce the pain. Okay. And the second line of treatment for this is the opioid analgesics and the tricyclic antidepressants. Okay. So here there will be severe scarring of the nerve involving the or supplying that particular dermatome. அந்த ஏரியா மட்டும் சப்ளை பண்ற நர்வுக்கு பேர் வந்து டெர்மட்டோம். எந்த ஏரியா அஃபெக்ட் ஆயிருக்கோ அதுல வந்து ரொம்ப சிவியர் ஸ்காரிங் ஆயிடும். ஸோ அதனால நியூரால்ஜியா மாதிரி அந்த பேஷண்ட்டுக்கு பெயின் எடுக்கும், என்னன்னே தெரியாம, without any cause there will be severe pain. Okay, for that the first line of treatment is gabapentin. The second line is opioid and the tricyclic antidepressants. Scarring on healing of oral ulcers is seen in recurrent after stomatitis major type. Okay, recurrent after stomatitis and zoster are the conditions where you will be seeing scarring of the oral ulcers. Bullous pemphigoids and vulgaris, you will be seeing autoimmune reactions which is directed against the desmosomes and hemidesmosomes. Okay. Solitary ulceration is most commonly seen due to trauma. Which of the following is most common clinical dermatological manifestation of allergy? Allergy nala first skin la vara manifestation enna appadina ஒரு மாதிரி itching மாதிரி இருக்கும் இல்லையா, that is called as urticaria. ஒரு itching மாதிரி இருக்கிறதுக்கு பேர் வந்து urticaria due to the action of histamines in that particular area. Vesicle or bulla is a fluid-filled lesion. If it is less than 1 centimeter, it is vesicle. If it is more than 1 centimeter, it is bulla. Petteke அப்படிங்கிறது வந்து சின்ன சின்ன ரத்தம் வந்த மாதிரி சாஃப்ட் பேலட்ல வந்து இரும்புனா சின்ன சின்னதா தெரியும் இல்லையா, ரெட் கலர்ல, அதுக்கு பேர் தான் வந்து பெட்டிகே. ஓகே. So the lesions of recurrent herpes stomatitis. Recurrent herpes stomatitis is found chiefly on the buccal mucosa on the floor of the mouth, hard palate and attached gingiva, soft palate and alveolar mucosa, anywhere on the oral mucosa. It is seen in the hard palate and the attached gingiva. Lutic glossitis is an intraoral manifestation caused by. Lutic glossitis is a manifestation of syphilis. Okay. Remember, syphilis is a very important topic with so many MCQs questions. Okay. Syphilis in edutale vandu too much of facts irukum, but it is very easy to answer. So just take it down. So it is an intraoral manifestation which is caused by Treponema palladium. Actinomycosis la pathinga appadina there will be sulfur granules which will be seen causing pus. And Streptococcus is a bacteria, and Mycobacterium tuberculosis causes tuberculosis. The tuberculosis lesion in the oral cavity may be of any form. It will be seen as ulcer, a granulomatous lesion, or anything. Okay. So lutic glossitis is an intraoral manifestation caused by Treponema palladium. So the stages of syphilis is divided into 3 different stages: the primary, secondary, and the tertiary. In primary stage, ஒரு சின்ன ulcer மாதிரி இருக்கும், painless papule that becomes ulcerated in the first 21 days. But when the patient is getting tested at this stage, the patient will be negative. Okay. In the second stage, it will actually get spread into the blood, and when the patient is tested at this stage, he or she will give a positive. In the second stage, the patient will manifest with maculopapular rashes. அதாவது கொஞ்சம் raised அதே மாதிரி கலர் மாறின மாதிரி சில rashes வந்து பார்க்கலாம் ஸ்கின்ல. Then the ulcers are seen, which is called as snail track ulcers in the oral cavity, and condyloma lata. So these are all the main oral manifestations. In the tertiary stage, it will affect the multiple organs, and certain growth is seen, which is called as a gumma. Okay, the interstitial glossitis is a rare finding, but it's a rare intraoral finding of the syphilis. When it transmits, or when it is vertically transmitted from the mother to the child will get affected, and these are all the features of the congenital syphilis: Hutchinson tree, mulberry molars, and the face of the patient will show frontal bossing, and the frontal bone இருக்குது இல்லையா, நல்ல தூக்குன மாதிரி இருக்கிறது தான் frontal bossing. Saddle nose is very depressed, and poorly developed maxilla. The maxilla will be poorly deficient. Okay. And angle of the mouth la pathinga appadina angular cheilitis மாதிரி ஒரு linear scar தெரியும், that is called as ruggeds. Okay, the ruggeds are seen as linear scar at the angle of the mouth. So syphilis becomes seropositive in the secondary stage. It's a direct question, easy. Canker sore is otherwise known as, I told you, right? Don't confuse with the cold sore and canker sore. Cold sore is herpes. This is recurrent aphthous ulcer. Canker sore is otherwise known as recurrent aphthous ulcer, which affects the lining mucosa. Okay. So this will have appearances like the ulcer வந்து சுத்தி ஒரு erythematous halo மாதிரி இருக்கும். So this is a typical appearance of aphthous ulcer. Intranuclear inclusion bodies is seen in herpes simplex virus infection, which is called as Lipschutz bodies. Okay, Negri bodies are seen in the dog bite condition, I think, and Donavian bodies are seen in the infection mononucleasis. Okay. Yes, it is rabies. Koplik spots is the first manifestation of measles, rarely seen in measles. It is seen 2 to 3 days after cutaneous rashes. It is a first manifestation, but seldom seen. Okay, so the option is, it is the first manifestation, but it is seldom seen. அதாவது நம்ம பார்க்க மறந்துருவோம். But Koplik spots are the intraoral manifestations of measles, which is also called as the rubiola. Okay, so these Koplik spots are red spots with minute bluish specks seen on the oral buccal mucosa. Buccal mucosa skin rashes வரதுக்கு முன்னாடியே வந்து இந்த Koplik spots தெரிஞ்சிரும், பட் ஆனா நம்ம வந்து பார்க்க மாட்டோம். So that is why it is called as the first manifestation, but seldom seen. Okay, ஒரு சின்ன அல்சர் மாதிரி இருக்கும் with a bluish hue. This is called as a Koplik spot. Whereas in German measles, you will be able to see certain petechiae on the soft palate. அதாவது கொஞ்சம் சின்ன சின்னதா வந்து erythematous spots மாதிரி இருக்கும் soft palate, which is called as Forchimius spots. Okay, so this is the Forchimius spots. Certain erythematous areas on the soft palate, raised erythematous areas on the soft palate. So this is typical to German measles. Chronic blistering skin disease is white spongy nevus, pemphigus, psoriasis, lupus erythematosus. It is actually pemphigus. Pemphigus is a chronic blistering disease which is seen in younger patients, which appears as blisters initially, and later on it will turn into ulcers, where the auto antibodies are directed against the desmosomes. Okay, desmosomes are cell to cell attachment which also has desmoglein 1 and 3. Okay, so அதனால என்ன ஆகும் அப்படின்னா epitheliumல there will be split, suprabasilar acantholysis ஆயிடும். So that is why the ulcers are very far spread and it will be very painful. So the main line of treatment here is steroids. Initially they will be giving topical steroids, and later on the steroids will be injected, and systemic steroids will also be given. Okay, systemic steroids like prednisolone will be given to the patient as a treatment of this form of ulcers. And in case of pemphigus vulgaris, certain specialized investigations are taken. That is IHC is done, and fishnet appearance of this is seen in pemphigus vulgaris. Okay, Symblepharon is seen in white spongy nevus, pemphigus, mucous membrane pemphigoid, lupus erythematosus. So mucous membrane pemphigoid is seen in elderly patients, affecting the hemidesmosomes. Hemidesmosomes அப்படிங்கிறது என்னன்னா கீழே வந்து பேசல் லேயர் இருக்கும், பேஸ்மெண்ட் மெம்பரேன், பேசல் லேயர்ல டால் காலம்னார் செல்ஸ் இருக்கும், அதுக்கும் பேஸ்மெண்ட் மெம்பரேனுக்கும் ஒரு கனெக்ஷன் இருக்கும். தட் இஸ் பை மீன்ஸ் ஆஃப் hemidesmosomes. Okay, so the auto antibodies will be directed against these hemidesmosomes, and then there will be a epithelial, there will be split causing ulcer. This is with respect to your mucosa, and later on it may affect the eyes of the patient, causing symblepharon. Okay, symblepharon is the adhesion between the palpebral and the bulbar conjunctiva. Okay, so இப்போ ஒரு அல்சர் பேஷண்ட் இருக்காங்க, and you do a biopsy and it is diagnosed as mucous membrane pemphigoid. Okay, so the first thing which you do is you refer the patient to a dermat for treatment or to see whether there is skin lesions, and then odane ophthalmologist we have to refer it, because these patients may get certain complications like this symblepharon, which will lead to blindness. Okay, later on it may lead to blindness, and it is very early intervention is very important in such kind of patients. As a dentist, we have to refer the patient both to the dermat and also to the ophthalm. Okay, and patient வந்து கிளினிக் வரும்போது இந்த மாதிரி பிளிஸ்டரோட எல்லாம் வரமாட்டாங்க. Okay, so this blister will not be very active. ஏதாவது சாப்பிட்டா உடனே இந்த பிளிஸ்டர் வந்து உடைஞ்சு போயிடும். It will form as an ulcer or a erythematous area. So buccal mucosa இருக்கும்போது it will form ulcer, whereas in gingiva it will be seen as a desquamation. Okay, so if there is desquamation of the gingiva, and what are all the possible lesions along with the desquamation அப்படின்னா, it is pemphigus, pemphigoid, and then lichen planus. Okay, lichen planus and linear IgA disease. So இது நாலுமே ஞாபகம் வச்சுக்கோங்க. If there is desquamation, and what are all the possible differential diagnosis, then it is pemphigus, pemphigoid, linear IgA, and lichen planus. Everything has to be biopsied, and then the treatment will be different for each conditions. Which of the following is associated with HIV infection? hairy leukoplakia, erythroplakia, oral lichen planus, bullous pemphigoid. It is oral hairy leukoplakia. Okay, oral hairy leukoplakia is associated with HIV. So some questions with respect to candidiasis. Which type of candidiasis? Sorry, red and white lesions. So which type of candidiasis is associated with leukoplakia? Acute pseudomembranous is something where you'll be able to scrape that white layer and it is very short span. Okay, followed by any administration of certain antibiotics. Okay, broad spectrum antibiotic ஏதாவது கொடுக்குறாங்க, ஹாஸ்பிட்டல்ல ரொம்ப நாள் அட்மிட் ஆயிட்டு பாத்தீங்க அப்படின்னா நிறைய ஆன்டிபயோட்டிக்ஸ் கொடுத்துட்டு அந்த பேஷண்டோட வாயில கொஞ்சம் அல்சர் மாதிரி இல்லைன்னா ஒயிட் கர்டி மெட்டீரியல் மாதிரி இருக்கும். ஸோ தட் இஸ் ஆக்சுவலி அ டைப் ஆஃப் அக்யூட் சூடோமெம்பரேனியஸ். அட்ரோஃபி அப்படின்னா எரித்தமேட்டஸா இருக்கும். அண்ட் ஆல்சோ தட் இந்த சூடோமெம்பரேனியஸை எடுத்ததுக்கு அப்புறம் பாத்தீங்கன்னா ஒரு எரித்தமேட்டஸ் லேயர் இருக்கும். தட் இஸ் called as acute atrophic. Okay, chronic atrophic, it is seen in patients like chronic denture varus. இப்போ டென்ச்சர் போட்டுட்டே இருக்காங்க, ப்ராப்பரா கிளீன் பண்ணல, டென்ச்சர் எடுத்து பாத்தீங்கன்னா அந்த டென்ச்சர் சுத்தி ஒரு அவுட்லைன் போட்ட மாதிரி, எஸ்பெஷலி இன் ஆர்பிடிஸ் யூ வில் பி சீயிங் some erythematous, அப்படியே typical erythematous areas will be seen. So that is a form of chronic atrophic type of candidiasis. Chronic hyperplastic is one which is non-scrapable, and there will be some epithelial changes due to the affinity of this candida to the altered epithelium. Okay, so this is one which is associated with leukoplakia, and also the chronic hyperplastic type of candidiasis is associated with HIV patients also. Okay, oral thrush develop in infants at 6 days, 2 to 6 weeks, 10 to 12 weeks, and 18 months. So initially they'll be having some amount of antibodies, so it is not 6 days, and 10 to 12 weeks is quite a long time, and 18 months is almost done. So it's the best option here is 2 to 6 weeks. Okay, so 2 to 6 weeks is a time where the oral thrush is developed, and many times you will be seeing some of the child ஒரு மாதிரி ஒரு white-ஆ வந்து ஒரு curdy material மாதிரி இருக்கு இந்த corners கிட்ட, இந்த buccal mucosa கிட்ட அப்படின்னு சொல்லிட்டு தெரிஞ்சிருக்கும். So if the infant's oral cavity is not cleaned properly, this kind of oral thrush is developed. Okay, so this is a classification which was given by Greenberg and Glick. And atrophyla, it is atrophyna erythematous இருக்கும், ரெட் கலர்ல தெரியும் oral cavityல. டென்ச்சர் போட்டாலோ இல்ல angle of the mouthல ஒரு சின்ன erosion மாதிரி இருந்தாலோ அது angular cheilitis. Median rhomboid glossitis is dorsal surface of the tongueல ஒரு சின்னதா erythematous area இருக்கும், and palateல there will be associated kissing lesion. So that is median rhomboid glossitis. And hypertrophic is candidal leukoplakia, papillary hyperplasia of the palate. These are all the hyperplastic forms. And syndromes associated with candidiasis is familial endocrine neoplasia syndrome and myositis. Okay, so if you get a picture-based image and telling that there is a white substance which is seen in the oral cavity followed by a broad spectrum antibiotic administration which is scrapable, it is candidiasis. And if you get a same picture with a different question like followed by the application of certain tablet, or followed by the application of administration of hot substances, there is a white material, then it is chemical burn. Okay, 2 lesions, remember, in the oral cavity, white lesion which is scrapable, one is candidiasis, the other one is chemical burn. So depending upon the history, you need to differentiate your diagnosis. So this is something related to your denture போட்டு அந்த இடத்துல வந்து சரியா கிளீன் பண்ணாம டென்ச்சரோட டிஷ்யூ சர்ஃபேஸ் சரியா இல்லாம போச்சு அப்படின்னா இந்த மாதிரி ரெட் கலர்ல இருக்கிறது chronic atrophy. So there the first line of treatment is you should ask the patient not to wear the denture for 15 days, and you should clean the denture on the tissue surface, and also you should give the topical antifungal, that is 1% clotrimazole should be applied on the tissue and also on the denture surface for at least 15 days to see the prognosis. Yes, so this is the treatment for candidiasis. Okay, earlier days amphotericin B was given, but amphotericin B எடுத்தோனே ஆப்ஷனா போடாதீங்க. Amphotericin B can be given very easily. It has to be given in a hospital setup. Okay, so once amphotericin B is given, it doesn't accept as such. There will be so much of changes taking place in your body, so much of electrolyte changes. Okay, and nystatin is a one which is given here in books, but when it comes to it is not available. Tell that it is not available in India. Nystatin is not available in India. Okay, only for the question options and for the exam purpose we are just learning it. And the available form is clotrimazole. Clotrimazole, it is available as candid mouth paint. The other forms or the other topical kalang kekla innume patient symptomatic irukanga appadina, you can always go for the fluconazole tablets. Half tablet is actually enough, and these are all some of the interactions of the drug. And again, you have to go back to the patient's history and then give the actual antifungal agent necessary. Okay, you can take a screenshot of this. How does yeast appear after gram staining? Red, blue, unaltered, none of the above. It's actually blue. Okay, so after gram staining it appears blue, and after periodic acid Schiff staining, it is not periodic acid Schiff, it is periodic acid Schiff staining, it appears red. Okay, and potassium hydroxide preparation is one easy method to see the yeast forms immediately. இது எல்லாமே வந்து ஸ்டெயின் பண்ணி நம்ம வெயிட் பண்ணணும். பட் ஒரு ஸ்லைட்ல வந்து ஸ்மியர் எடுத்துட்டு உடனே ஹைட்ரஜன் பெராக்சைட்ல டிப் பண்ணி நம்ம பார்த்தோம்னா the different forms of yeast வந்து we will be able to see. Treatment of leukoplakia is antioxidants, steroids, antibiotics, surgery. So leukoplakia is a white lesion which is seen in patients with severe smoking habit, okay, or if there is no other history. In such cases, the mucosa is altered, and if you give steroids, it will again worse, and it is not a one which has to be treated with antibiotics. Okay, so antioxidants, out of these options, antioxidants is best, and if there is an option like A and D, you can give A and D. Actually surgical incision we can actually take it and go it for a biopsy, and then we can do it a excisional surgery. So initially, if there is any cause, we have to remove the cause, and if there is no cause, then we have to do a biopsy, and then we have to treat accordingly. The next is pigmentations. We'll see some of the questions. Hemoglobin pigment deposition is seen in which of the following? Hemangioma, Kaposi's sarcoma, angiosarcoma. So hemangioma, there will be hemoglobin pigmentation. Kaposi's sarcoma is due to HH8, and it is a tumor seen most commonly in HIV. And angiosarcoma is a sarcoma which is related to the endothelial cells. So it's all of the above. Which of the following is due to hypoadrenalism? In both hypo and hyperadrenalism, there will be pigmentation of the skin and the oral mucosa. And the question is, which is due to hypoadrenalism? It is actually Addison's disease. Okay, so Peutz-Jeghers disease, there will be pigmentations in the lips, which is seen as macule, and along with that, there will be some of the changes in the intestine. Okay, and Sjogren's syndrome is something autoimmune, so we'll be dealing it with the salivary gland chapter. And Cushing's syndrome is due to excess hormonal activity of the ACTH. Okay. And in Addison's disease, the intraoral pigmentation is seen as blotches of ink. Okay, blotches of ink na ink அப்படியே வந்து மேல ஷர்ட்லயோ இல்ல ட்ரெஸ்லயோ வந்து போட்டோம்னா வந்து எப்படி ink செதறன மாதிரி இருக்கும்ல, அந்த மாதிரி வந்து the pigmentations will be seen. So which of the following drug can cause oral pigmentation? Minocycline and tetracycline are broad spectrum antibiotics, and quinidine is the one which is treated as an anti-malarial drug. And in all this, there will be pigmentations of the mucosa, either in the teeth or in the bone. Okay, so minocycline has an affinity towards absorption of the drug to the bone and also to the metabolites, to the teeth, and hence there will be pigmentation of the teeth due to all these drugs. An example of post-inflammatory pigmentation is lichen planus, lupus erythematosus, pigmented nevi, varix. So pigmented nevi is normal, and lupus erythematosus and lichen planus comes in the, it is actually considered. But here the correct option is lichen planus. So lichen planus, it appears as either white or erythematous areas in the skin and the oral cavity, and when it is treated properly with steroids, during the healing phase, it will be dark brown or black in color, which shows that the lesion is healing. Okay. So this is a very quick chart which shows that what has to be done if there is a pigmentation in the oral mucosa. So remove the cause, and we have to locate, and we have to see what color the lesion is. Red color irukka illa vandu blue black color la irukka appdin paakrom. Okay, so blue black color la irundichu appadina diffuse ah irukku. If the patient itself is dark along with some gingival pigmentation, then you should think about physiological pigmentation. Okay, and if the patient is obese with certain hormonal changes, then you should think about endocrine disorders. Okay, and if the patient is having any habit, then it is mucous melanosis. And drug history, again drug induced pigmentation. And if the patient is taking drugs for any skin disorders, then it is post-inflammatory inflammation. And HIV infection, certain drugs may cause pigmentation. Okay, and followed by that, if there is only focal pigmentation, the most common focal pigmentation, focal bluish black pigmentation, is melanotic macule, most commonly seen in the females. And if it is tumor associated, it is malignant melanoma, or in infants it is neuroectodermal tumor of infancy. Okay, idhula edume fall agala. The extrinsic pigmentation அப்படின்னா metal poisoning or due to any amalgam tattoo or presence of any chromogenic bacteria or food stains. You should think about this. And if it is red, if it blanches, then there are certain conditions which is related to that. That is hemangioma, varices, hematoma. And if it doesn't blanch, it is only superficial. அதாவது மேலாப்ல மட்டும் தான் இருக்கு அப்படினு அர்த்தம். Petechiae, ecchymosis, hemochromatosis, which doesn't blanch. Okay, so I'll show you a picture for the blanching. Okay, the test is called as diascopy. I'm having the picture. I'll just show you in the coming slides. So which of the following is caused due to extravasation of blood into soft tissues? It's actually all of the above. Okay, which of the following shows tramline calcification on skull? Tramline or train madri skull radiography edutha calcification mari theriyum. That is actually Sturge-Weber syndrome. Okay, Sturge-Weber syndrome. Sturge-Weber syndrome is also called as trigeminal-encephalomyomatosis. Okay, it will cause port vein stain, trigeminal nerve la. So we have seen about the zoster, trigeminal neuralgia patti paathirkom. So the syndrome associated or the syndrome with some trigeminal name is trigeminal-encephalomyomatosis, involving the trigeminal nerve, the skull, the tramline calcification, and the patient will give history of epilepsy. Okay, according to Clark classification of melanoma, the level 3 is, when it comes to melanoma, you should know about two different classification. One is Clark, the other one is Breslow. Okay, so here the level 3 is again a direct question, invasion which is up to the reticular dermis. So this level is up to level 5. Okay, the green discoloration frequently seen in children. When it comes to children and there is discoloration, which is very common, அதாவது வந்துட்டு போற மாதிரி ஒரு எபிசோட் இருக்கு அப்படின்னா, it is mostly chromogenic bacteria. Inherent-ஆ இருந்துச்சுன்னா, then you should again think about certain drugs intake. Intraoral pigmentation is seen in Kaposi's sarcoma, Addison's, Peutz-Jeghers, all of the above. It's all of the above. LKB1 gene mutation results in. There will be some of the questions with respect to gene, which is not very repetitive. Okay, ஒரு question gene mutation, ஒரு question வந்து inheritance, இந்த மாதிரி they often ask, but luckily if you know the answer, it's good. Here the option is C. Okay, Peutz-Jeghers syndrome. The varicosities of the oral cavity is chiefly seen on the ventral surface of the tongue. So when you see the elderly patients, நாக்க மேல தூக்கி பார்த்தோம்னா நல்ல prominent-ஆ இருக்கும் தெரியுமா இந்த varicosities. So that is seen on the ventral surface of the tongue, which is also called as the caviar's tongue. Caviar's tongue. Okay. So here is a image-based question telling that there is an amalgam restoration, and followed by the amalgam restoration, there is discoloration of the mucosa. Okay. So it is lichenoid reaction. அதாவது lichen planus மாதிரியே வந்து reaction இருக்கும். ஆனா autoimmune cause கிடையாது. amalgam இருக்கிற காஸ்னால it is called as lichenoid reaction. And so here is a patient with a skin and a tongue lesion, and the tongue appears bluish with a bluish hue, and followed by the administration of steroids, the lesion and the burning sensation of the patient is reduced. Okay, so it is most likely lichen planus. Okay, so read the scenario properly, and if the picture is also given, see the picture properly and then you can answer. And here is a yellowish discoloration of the mucosa with the patient giving history of increased or elevated temperature, jaundice. Okay, and here the patient gives history of tetracycline intake during the mixed dentition or during her 5 years. இந்த மாதிரி வந்து கேக்குறாங்க அப்படினா it is discoloration due to the drugs. Okay, next is some questions related to salivary gland disorders. The salivary gland stone, the salivary calculi is most commonly seen in the submandibular gland due to its location, due to the calcium content, and also since it is against the gravity. Okay, and the patient will be giving symptoms like there will be pain just before the meals. சாப்பிட்றதுக்கு முன்னாடி ரொம்ப acute pain இருக்கும், and then when you milk the saliva in that particular area, it will be not able to see. Okay, so this is a picture based question along with the scenario. Okay, so இது வந்து first ஒரு occlusal எடுத்து பார்க்கறாங்க. இதோட density, இந்த teeth density விட இது கம்மியா இருக்கு, and then if you see lateral oblique, you are able to see multiple radiopaque foci, and then when you operate it, you are able to see some of the salivary gland calculi in the salivary gland. So if it is very small, you can actually remove it. If it is very large, you have to involve the entire gland. Okay, non-inflammatory non-neoplastic enlargement, அதாவது இன்ஃப்ளமேஷனும் இல்ல நியோபிளாசமும் இல்லாத என்லார்ஜ்மென்ட்க்கு பேர் என்ன அப்படினு கேக்குறாங்க. It is called as cyelosis or cyeladenosis. Cyeladenitis is inflammatory, bacterial cyeladenitis, viral அப்படினா இது வந்து inflammatory. Tylism is increased saliva. Siluria is also condition associated with increased saliva. So in case of tylism or siluria, the main treatment will be atropine sulfate na kudupom. Okay, so it is an anticholinergic drug which is given to control the increased saliva. Adu saliva mattu control pannadhu, secretions ellame vandu it will control. So these are all the inflammatory conditions of the saliva. Mucocele ranula, idella vandu due to the trauma of minor salivary glands, there will be accumulation of the mucin, and followed by that silolithiasis, there will be inflammatory enlargement. And non-specific cyeladenitis is bacterial cyeladenitis, necrotizing cyelometaplesia, and chronic sclerosing cyeladenitis or Kuttner's tumor is especially the tumor seen in the submandibular gland. Okay, the viral induced salivary gland pathology is seen in HIV and mumps. So these are all non-inflammatory conditions associated with enlargement of salivary glands. Cyeladenosis, anorexia or bulimia, eating disorders. Okay, so these are all the eating disorders. The patient will have more urge to eat, and then they'll vomit, and due to that effect, there will be enlargement of the salivary glands. Okay, and chronic alcohol patients with they'll also have this kind of enlargement. And in case of diabetes mellitus and certain medications and certain disorders like granulomatous disorders also causes non-inflammatory enlargement of the salivary glands. So reduction of the salivary flow is not generally seen in diabetes, radiation therapy, phenothiazine drugs, இவங்க எல்லாத்துக்குமே saliva குறைஞ்சிரும். Okay, it will not lead to xerostomia, but relatively it will get reduced. But in case of Parkinsonism, the symptom itself is excessive salivation. Okay, so medications is so xerostomia is mainly due to medications and due to radiation of head and neck and certain systemic disorders like Sjogren's, sarcoidosis. Okay, and the viral infections which lead to xerostomia is HIV and hepatitis C. So hepatitis C, which virus is actually related to lichen planus? Abdina, it is hepatitis C. Okay. And these are all some of the drugs which can lead to xerostomia. So normally, just know the drugs, and based upon this, you will get certain questions like if the patient is under anti-diabetic drug, or if they may give you as a name itself. கொஞ்சம் நார்மலி இருக்கிற மெட்ஃபார்மின் இந்த மாதிரி ஏதாவது ரொம்ப காமன்லி யூஸ் பண்ற ஆன்டி டயபெட்டிக் ட்ரக்ஸ், கிளைபன் கிளைமைட் குரூப் இந்த மாதிரி எல்லாம் கொடுத்து they may ask you the question itself. Okay, so just know the group of drugs. So antihistamines அப்படின்னா like not the generation, first generation, second generation அளவுக்கு இல்லைனா கூட அட்லீஸ்ட் செட்ரசன் இந்த மாதிரி கொஞ்சம் வந்து தெரிஞ்சு வச்சுக்கோங்க. Okay, the proton pump inhibitors, the anti-HIV drugs like protease inhibitors, benzodiazepines. Okay, so these are all the drugs which causes xerostomia. The most common parotid gland tumor arising in children is. So when it comes to parotid gland tumors, some of the tumors which is common to parotid, submandibular, adult and young patients, smoker patients, idellame it's a very commonly asked and the easy questions to remember. So pleomorphic adenoma is the most common benign tumor and the females are most commonly affected. Okay. When it comes to Warthin's tumor, which tumor occurs bilaterally? Abdina, it is Warthin. Which tumor is most commonly associated with smokers? Now, Warthin's. Which is seen in older males now? It is Warthin's. The mucoepidermoid carcinoma is the most common malignancy which occurs in parotid gland in about 40 to 70%. Okay. The adenoid cystic carcinoma is the overall second most common malignancy seen. So these are all some of the common facts with respect to the tumors of the salivary glands. In the clinical evaluation, the most significant finding of the parotid mass is accompanied by, okay, clinically ஒரு பேஷண்ட்டை பார்க்கும்போது parotid mass தெரியுது, parotid regionல வந்து ஒரு பெரிய growthோ மாஸோ தெரியுது. ஸோ அப்படி இருந்துச்சுன்னா என்ன ஃபர்ஸ்ட் நம்ம பார்ப்போம்? rapid progressive painless enlargement, nodular consistency, supramental and preauricular lymphadenopathy, facial paralysis. It's actually facial paralysis. Why? Because the question is the most significant finding in a very short period is you have to go for a facial that is facial paralysis irukkan paakano. Apdi irunduchuna it is more likely to be malignant. Okay, nodular consistency irunduchu appadina it is most likely to be pleomorphic adenoma. So நம்ம consistency பார்க்கிறதுக்கு முன்னாடி we should ask the question like facial paralysis இருக்கா அப்படின்னு சொல்லி பார்க்கணும் when you see a growth in the parotid region. Okay, which of the following statement is false? So I'll just give you the option. The sublingual salivary gland is the most common site of salivary gland neoplasia. No. The minor salivary glands is the most common site of neoplasia. Okay. Major salivary glands involved pannichu abdina, it will be more likely to be benign. If it involves a minor salivary gland, it is most likely to be malignant. This is one clue. Okay. Warthin's tumor, papillary lymphadenomatosa. Okay, it is also called as a adenolymphoma of the parotid because it has two components, adeno component and the lymphoid component. So that is why it is called as papillary lymphadenomatosa. The most common salivary gland malignant neoplasm arising in the bones is mucoepidermoid carcinoma. அதாவது salivary gland மாதிரி ஒரு ஸ்ட்ரக்சர் ஹிஸ்டோபேத்தாலஜிக்கலா பார்க்கும்போது salivary gland components இருக்கும், ஆனா வந்து போன்ல இருக்கிற டியூமர், அதான் क्वेश्चन. So it is mucoepidermoid carcinoma. So this option also has an important feature like the complications of dentigerous cyst. Okay, the complications of dentigerous cyst abdinale you should think about three different entities. One is ameloblastoma, the other one is mucoepidermoid carcinoma. Okay, So the most common salivary gland malignancy which involves a bone is the mucoepidermoid carcinoma. So it may be in a low grade form or a high grade form. So if the high grade form will behave like a squamous cell carcinoma itself, like an ulceroproliferative growth. Bimanual palpation, palpating with two hands, it's called bimanual palpation, is carried out for which salivary gland? It is actually submandibular salivary gland. A painful crater like 1.5 centimeter ulcer develops within 1 week on the hard palate over in a 40-year-old female. Most likely diagnosis is an ulcer with a less duration in a female is necrotizing xylometaplasia. Necrotizing xylometaplasia, the appearances will be very similar to malignant growth, but the duration will be very less. Okay, only metaplasia of the epithelium will be seen, but nothing serious. It is self-healing. It doesn't cause any side effects, or it doesn't cause any serious effects rather. Which of the following parotid malignancy shows perineural spread? It's a direct question. Again, adenoid cystic carcinoma. Xylography is used to detect anomaly of both the salivary gland and the duct. Okay, ductல ஏதாவது பிரச்சனை இருந்துச்சுனாலும் சரி, glandல ஏதாவது பிரச்சனை இருந்துச்சுனா ரெண்டுமே வந்து xylography. Acute non-suppurative xylodenitis is seen in acute, okay, whereas it is non-suppurative. It is seen in mumps. Yes. So it is mumps is caused by paramyxovirus group, and it's seen in childhood with an incubation period of 2 to 3 weeks. But the side effects of mumps may affect the adult patient in adult also. A cyst occurs under the tongue caused by obstruction of the salivary gland is called as, okay, if it is under the tongue, then it is called as ranula, frog belly. Okay, if it occurs in the labial mucosa or anywhere in the buccal mucosa, it is called as a mucocele. But if it occurs in the undersurface of the tongue, it is called as the ranula. Frog or the belly mari irukum. So that is why it is called as ranula. And the blue effect or the blue tinge of this ranula or the mucocele is due to Tyndall effect. The most common complication of mumps is orchitis. Leafless fruit-laden tree or cherry blossom appearance on a xylogram indicates Sjogren's syndrome. Okay, so leafless fruit-laden tree or cherry blossom appearance is due to seen in Sjogren's syndrome. So this is the image post xylography. Xylography எடுத்ததுக்கு அப்புறமா எடுக்கிறது தான் வந்து இப்படி image தெரியும். So Sjogren's syndrome includes all of the following except xerostomia, keratoconjunctivitis, arthritis, lymphoma. So it's lymphoma. So Sjogren's syndrome may be divided into primary and secondary. Okay, so Sjogren's syndrome is called because it has to satisfy the following criteria. 6 different criteria இருக்கும். 3 வந்து with related to the ocular and 3 with respect to the oral cavity. What are all the ocular symptoms the patient has, the oral symptoms the patient has, ocular signs. Signsல தான் இந்த டெஸ்ட் பேர் எல்லாம் வரும். The Schimmer's test, the Rose Bengal test, இதெல்லாம் வந்து the signs which or the test which the physician does. Okay, and the gold standard for the diagnosis of the Sjogren's syndrome is histopathology or biopsy of the lower labial mucosa. Lower labial mucosa வந்து biopsy பண்ணிட்டு எத்தனை inflammatory lymphocytes இருக்குன்னு சொல்லி கவுண்ட் பண்ணுவாங்க. So ஒரு ஃபோக்கஸ்க்குள்ளார ஒரு 50 இருந்துச்சுன்னா then it is positive. Okay, and apart from that, salivary stimulations, autoantibodies. So all this they do to diagnose whether the patient is suffering from Sjogren's syndrome. And along with Sjogren's syndrome and any other connective tissue disorder, it is called as secondary Sjogren's syndrome. Okay. Dilation of the salivary duct secondary to epithelial atrophy as a result of repeated inflammatory or infectious process is xylodocitis. So xylodocitis, the xylographic appearance is important. Sausage link appearance. Okay. Salivary gland aplasia is seen in hemifacial microstomia, LAD syndrome, mandibulofacial dysostosis, that is Treacher-Collins syndrome, all of the above. LAD syndrome is nothing but lacrimo-auriculo-dentodigital syndrome or Levy-Hollister syndrome. Okay. So LAD syndrome is lacrimo-auriculo-dentodigital syndrome, and hemifacial microstomia and mandibular facial dysostosis. These are the conditions where there will be absence of the major salivary glands. So xerostomia is seen in all of the following except oral sepsis. Anticholinergic dehydration, Sjogren's. இது எல்லாத்துலயுமே xerostomia இருக்கும். Oral sepsisல நிறைய saliva produce ஆகும். Cribriform honeycomb or Swiss cheese histology is seen in adenoid cystic carcinoma, pleomorphic acinic cell, clear cell. It is adenoid cystic carcinoma. Spindle cell carcinoma is a variant of squamous cell carcinoma. Breakup time test is done for Sjogren's, multiple sclerosis, SLE, myasthenia gravis. Apart from Schimmer's and Rose Bengal test, breakup test is also a test done for diagnosis of Sjogren's syndrome. Xylography of normal salivary gland reveals leafless tree. Sausage string in Xylodochitis, fruit-laden in Sjogren's, ball and hand is benign tumors, leafless tree is normal appearance. Okay. So here, if you get a question like in anorexia nervosa or in patients who are vomiting, who have the regular regurgitation, vomiting, and due to the acidic content of the gastric contents, there will be erosion of the anterior teeth. This teeth is all normal, but from here you can see some erosion of the anterior teeth. So this condition is called as peremolysis. Peremolysis. Okay, where there will be erosion of the palatal surface of the anterior teeth due to the reaction of the acidic contents. Diagnosis of Sjogren's syndrome is confirmed by lip biopsy. Okay, gold standard. So what percentage of sublingual salivary gland tumors is malignant? It's 85%. So here there is a picture of the patient who shows enlargement of the salivary gland. Okay, when this gland is milked, parotid papilla. Parotid papilla is where there will be opening of the parotid gland in that particular area opposite to the second molar approximately. And if you try to take that pus and then give for culture, okay, you will be able to differentiate what organism is responsible to cause the infection, and then after that sensitivity test we can give the antibiotics. Okay, so these are all some of images which shows the equipments which is needed to collect saliva. Okay, you can just take a screenshot of this and you can see it later. And this is the values of the resting saliva and the stimulatory saliva of the whole the parotid gland, the submandibular gland, and as such as a total. Okay, resting na normala vandu in the stimulatory saliva is one which is taken after chewing bubble gum or paraffin or rubber band. Okay, the chew pandradhukku substance kudutittu edukradhukku per vandu stimulatory saliva. Resting saliva is we'll ask the patient to sit in calm place for some time, and then the saliva is collected after 1 minute, after 2 minutes, after 5 minutes. Okay, so this is measured. And this is the pH. Yes. So mostly I'll finish it by 1:30. Okay. There are some of the few topics are left. We'll see. The trigeminal neuralgia, the true statement is it causes paralysis of one side, uncontrollable twitching of muscles, sharp excruciating pain. Yes, the option is C. So trigeminal neuralgia causes sharp excruciating pain, and it most commonly affects the maxillary division, and the right side is most commonly affected. Okay, this is also one common important question asked. Right side abdina, they have done so many cadaver studies, and they have found that right side la irukra and foramen ovale irukudhu illaya, adoda dimension vandu comparatively to the left side it is less. So that's why the right side is most commonly affected. So the other names are doloris, trifacial neuralgia, and Fothergill's disease. It is very unilateral, and the patient gives pain only in the trigger zones, and due to that And if it is in older patients, or sorry, if it is in younger patients, you have to always evaluate to rule out any tumor. Okay. The geniculate neuralgia is associated with which cranial nerve? It's actually the facial nerve, where the patient will have pain in the ears, and the patient will feel a typical hot stick inserted into the ear. The other name for geniculate neuralgia is nervus intermedius neuralgia. Trotter's syndrome involves. So Trotter's syndrome is a combination of soft palate paralysis, trigeminal neuralgia, and which is seen most commonly in the tumor of the nasopharynx. Okay. Horner's syndrome does not involve ptosis, anhidrosis, flushing, mydriasis. Horner's syndrome is again a triad of absence of sweating, drooping of the eyelid, and the pupil size will be small. So the option is mydriasis. Frey's syndrome results from the surgery of parotid gland, submandibular salivary gland, TMJ, sublingual salivary gland. So it's an injury to the auriculotemporal nerve due to the surgery of parotid gland, and it's tested by means of the starch iodine test. Okay. Gustatory sweating. So which of the following is not a characteristic drug of choice for trigeminal neuralgia? Carbamazepine, acetaminophen, phenytoin sodium, baclofen. So carbamazepine and phenytoin sodium are antiepileptic drug, and baclofen is a muscle relaxant. Acetaminophen is nothing but plain paracetamol. Okay. So this muscle relaxants and antiepileptic neuralgia, but acetaminophen doesn't have any reduction of pain here. Okay. So if the patient is diagnosed with a neuralgic pain, initially they'll start with carbamazepine, that is Tegretol, 100 mg twice daily will be given. And if the patient is resistant to Tegretol, then the alteration of the drug, that is phenytoin sodium, is given. Okay. And over a period of time, again, if the patient doesn't respond to this, then we can increase the dose up to 600 milligram per day. Okay. And if again the patient is resistant to all this, then a combination therapy of carbamazepine, oxycarbamazepine, and gabapentin is given. The second line of drugs for choice is baclofen, lamotrigine, and pimozidine. So these are all some of the drugs which is given alternatively. Okay. In refractory cases, or if the patient doesn't respond to this drug therapy, then surgery. Microvascular decompression or percutaneous radiofrequency thermocoagulation is done to actually reduce the compression, nerve compression, okay, along the ganglion. Burning mouth syndrome. Burning mouth syndrome is nothing but the patient will have typical burning sensation without any ulcer, without any lesion, or without any disease. In the history mein irukama, the patient will have burning sensation. Okay, it is not psychological also. But as a physician, we should always treat the patient. Okay, the main treatment of this burning mouth syndrome is actually topical clonazepam. Okay, diazepam, clonazepam group of drugs vandita. We have to ask the patient to suck and spit, not to swallow. Okay, and alpha lipoic acid, tricyclic antidepressants, and cognitive behavioral therapy. So these are all the treatment options for burning mouth syndrome. So which of the following is not associated with vascular origin? Cluster headache, giant cell arteritis, anesthesia dolorosa, chronic paroxysmal hemicranias. Okay. Vascular origin illama edu irukuna, and that is anesthesia dolorosa. Anesthesia dolorosa அப்படிங்கிறது an anesthetic feeling which is seen in a particular area even after the effect of the anesthesia is gone. Okay, but the other types, it is associated with headaches. So here you can see a word like abortive and prophylactic. அதுக்கு மட்டும் மீனிங் சொல்லிடுறேன். Abortive அப்படின்னா என்னன்னா, தலைவலி வரதுக்கு முன்னாடி. So these are some of the type of headaches where the patient will have episodes. அது முன்னாடியே தெரியும். ஒரு சில பேருக்கு தான் வந்து இந்த மைக்ரேன், ஒரு சில பேருக்கு தான் இந்த கிளஸ்டர் ஹெடேக் எல்லாமே தெரியும். பட் இந்த ஹெடேக் வரதுக்கு முன்னாடி these patients may experience certain symptoms. ஓகே, அந்த சிம்டம்ஸ் வரும்போதே இந்த ட்ரக்ஸை எடுத்துக்கிட்டோம்னா அந்த எபிசோடையே அவங்க வந்து தவிர்க்கலாம். சப்போஸ் அந்த சிம்டம்ஸ் வந்துருச்சு அப்படின்னா then they have to go for prophylactic. Okay, abortive is something during the period of the before the pain starts. Okay, so this also you can take a screenshot and then you can go through it. In toothache, the referred pain is felt in A delta fibers or C fibers. Okay, so referred pain or the chronic pain is seen by means of the C fibers, whereas the A delta fibers is something which is myelinated. Okay, so with respect to pain, there are two different fibers which carry the sensation. One is the A delta, the other one is C fibers. So I'll tell you very fast only with the trigeminal system. So if there is a pain from the tooth, okay, there will be different nucleus of the trigeminal system which will carry the impulses from the area of the pain to the spinal tract nucleus. Okay, then it will cross the midline and it will reach the thalamus. From the thalamus, it will be taken to the higher center. Okay, in the இடத்துல வந்து you can see one dotted line and one continuous line. This dotted line எப்படின்னா என்னன்னா, these fibers are taken by the C fibers. This pain is taken by the C fibers and this is taken by the A delta fibers. Okay, the A delta fibers, since it is myelinated by means of saltatory effect, the pain will reach the thalamus very fast, whereas the C fibers, the pain will be taken very slowly. So that is why referred pain or chronic pain is taken by the C fibers by means of paleo-spinothalamic tract, and by means of neo-spinothalamic tract, the C fibers will carry the pain through the thalamus, and from the thalamus to the cortex, this pain will be experienced by the patient. So descending neurons. So that is the ascending pathway of pain, whereas the descending pathway of the pain is something which controls the pain by means of the normal substances released by the body, which has functions similar to that of the opioids. Okay, opioids is something which is given to actually reduce or decrease the pain in the higher center. And the madri odambalaye sila substances வந்து secrete ஆகும், like serotonin இந்த மாதிரி எல்லாம். So this opioids is responsible to decrease this pain, and this kind of substances is secreted by the human body itself. So that reduces the pain as such naturally. So that is called as the descending neurons. So which is the major risk in temporal arteritis? It is actually blindness. TMJ, which is the condition in which condyle is deviated to the affected side. Condyle வந்து affect ஆகிற சைடு எந்த கண்டிஷன்ல இருக்கும் அப்படின்னா, it is both ankylosis and fracture. Okay, so that ankylosis fracture ரெண்டு பக்கமுமே, if the right side is affected, then your jaw will deviate to the right side. That's the question. So here is a picture which shows the deviation of the condyle towards the left side. So something, so you can give a differential diagnosis of either fracture or ankylosis in that particular side. Which is the condition in which the condyle appears like a taut stool? Rheumatoid arthritis, juvenile arthrosis, osteoarthritis, none of the above. It is juvenile arthrosis. Okay, the appearances of condyle in certain conditions is I've given as a picture. So taut stool அப்படின்னா ஒரு mushroom. Okay, so this is the type of taut stool appearance which is seen in young patients, where there will be flattening and the elongation of the articular surface of the condyle. Okay, there is one condition that is called as agenesis of the condyle. அதாவது condyle வந்து இருக்காது. It is seen in golden hair syndrome, hemifacial microsomia, and Hallermann-Streiff syndrome. Okay, and double condyle or bifid condyle. Bifid condyle is most commonly seen in the coronal view. And so it is seen in the coronal view of the CT, and it appears as a cilate heart shape. Heart-shaped condyles are seen. It is seen in the frontal or sagittal plane, or there may be an actual duplication of the condyle, resulting in the appearance of the bifid head. So there is one condition called as the Jacobson's disease. Okay, what will happen is this: the coronoid process will be very large, so that it will get fused with the zygomatic arch, and hence the patient will not be able to open the mouth widely. Restricted mouth opening irukkum. So that is called as coronoid hyperplasia, seen in Jacobson's disease. So here is an image showing the condyle with some radiolucency, called as the Ellis cyst, seen in osteoarthritis. Okay. So this is a sagittal tomograph of the TMJ showing then osteophyte and the joint mice cases. So joint mice, Ellis cyst, it is a feature of osteoarthritis. Okay. Here the condyle is pencil shaped and there is a steep mandibular angle, and it is seen in elderly patient bilaterally. So this is a feature of rheumatoid arthritis. Pencil shaped condyle. Okay. So the shapes of the condyle is very important. Pencil shape, toadstool shape, and bifid condyle, agenesis of condyle, diffusion of the coronoid process. Yes. So this is a condition called as Tistle's disease. It is called as juvenile rheumatoid arthritis. Okay. And these are the pictures showing fracture of the condyle. Next, some questions related to cyst and tumors. The Carnoy solution is used in the treatment of odontogenic keratocyst. Okay. So odontogenic keratosis is a tumor with higher recurrence rate, and it appears the anterior posterior growth of the tumor is very high and most commonly seen in the posterior mandible. The peak incidence of Gorlin cyst is calcifying epithelial odontogenic cyst. The peak incidence of this cyst is second and third decade of life. Okay, so the typical radiographic appearance is driven snow appearance, and there will be presence of ghost cells in this Gorlin cyst. Okay, so most commonly it is seen in the maxilla, and the canine is the most common region. And if it is present in the mandible, the posterior mandibular region is most commonly seen, and this is seen along with the presence of ghost cells. Okay, the ghost cells is seen in other odontogenic tumors also, like odontomas, ameloblastomas, adenomatoid odontogenic tumors, ameloblastic fibroodontomas, and ameloblastic fibromas. So odontomas are the most common odontogenic tumors, and there are two types of odontomes. One is complex, the other one is compound. Complex is nothing but an accumulation of the calcified structures which doesn't have a tooth-like structures, and it is most commonly seen in the posterior mandible, and the cyst associated with odontome is dentigerous cyst. Whereas in compound odontome, it will be like a tooth-like structures. That is enamel, dentine, pulp. This is easy identify pannala. So adanaala adukku per vandu compound odontome. It is seen most commonly in the anterior maxilla. Okay. Cystic keratotic nodules occur in almost 65 to 85% of the newborn. Okay, cystic keratotic nodules are seen in almost 85% of the newborn, and it will disappear over a period of time. The Rushton bodies are seen in dentigerous cyst. The second most common cyst is dentigerous cyst, and it is most commonly associated with the impacted teeth, where there will be displacement of the teeth. Okay. Radiographically, you see there will be displacement of the teeth, and there will be cortical expansion also, and there will be presence of Rushton bodies, and most commonly it is seen in the impacted teeth. And the three radiographic types are circumferential, lateral, and which is not true for odontogenic keratocyst. It has high recurrence rate, arises from the remnant of dental lamina, show presence of microscopic daughter cells, common in maxilla. It's actually common in the mandible. Which of the following cyst is also known as incisive canal cyst? Incisive canal is something related to the maxillary anterior. So the most apt option here is median anterior maxillary cyst. The globulomaxillary is seen in the lateral surface, that is in between the canine and the lateral. The nasolabial is also called as cyst, which causes obliteration of the nasolabial fold. The median mandibular cyst is seen in the mandibular anterior region. The soap bubble appearance of bone. Soap bubble is a multilocular appearance which is seen in the bone. It is seen in aneurysmal bone cyst. Okay. So the aneurysmal bone cyst, the traumatic bone cyst, or the cyst which doesn't have any epithelial lining, and the possible etiology will be fibrous dysplasia. That patient may be diagnosed earlier with fibrous dysplasia or central giant cell granuloma, and then later on we have this aneurysmal bone cyst like lesion. Okay. Which is true about traumatic cyst? The males are commonly affected than females. The mandibles are most commonly involved. Most frequently it is seen in younger persons, all of the above. So the option is all of the above. Traumatic bone cyst, it's an empty cyst, it doesn't have any content in it. Okay. So when clinically, when we open the cyst, if there is cheesy material seen from the cyst, then it is odontogenic keratocyst. And when you open the cystic wall and you see nothing, it is most likely traumatic cyst. So these two different types of cyst you can actually diagnose during the surgical procedure itself. And traumatic bone cyst is seen in association with florid osseous dysplasias. Okay. The cystic keratin filled nodules found along the mid-palatine raphe is derived from Epstein pearls, seen in children, infants rather. Which of the following syndrome is characterized by basal cell carcinoma, multiple OKC, congenital blindness, mental retardation, and hypogonadism? It is Gorlin-Goltz. Goltz-Gorlin is focal epithelial hyperplasia. Gorham syndrome is vanishing bone syndrome, and golden hair is what we saw in the agenesis of the condyle. Okay, only one half of the face will be developed, the other half will be not. That is golden hair. Ghost cells are seen in all of the above. Yes, we have discussed it. Aneurysmal bone cyst does not include. It includes history of trauma, giant cells, blood-soaked spongy appearance, but it is not lined by squamous epithelium. So as I told you, aneurysmal bone cyst and traumatic bone cyst doesn't have a lining. These are pseudocyst. Which of the following is associated with high recurrence rate? It is again OKC. Bilateral mandibular expansion is seen normally in. So it is seen in cherubism. So it has different grades to actually categorize: grade 1, grade 2, grade 3, and grade 4, which involves different areas of the maxillofacial region. Okay. What is the other name for nasoalveolar cyst? Pinberg tumor, when stained by Congo red and examined under polarized light, appear as apple red. So Pinberg tumor is other name for calcifying epithelial odontogenic tumor. It's associated with impacted tooth, 50%. The growth of OKC takes place mainly in the anterior posterior direction. That is why there will be no expansion or no cortical reactions. Anterior posterior. Dermoid cyst is a form of hamartoma. Okay, hamartoma is a condition where there will be abnormal growth of the particular tissue, the growth of which will stop once the person's growth is stopped. Example is odontome and dermoid cyst also. Okay. So this is a picture which shows the occurrence of the developmental soft tissue cyst. This is the area where the nasolabial cyst is seen, causing obliteration, and this is the site of median alveolar or median mandibular cyst, and this is A pear-shaped radiolucency which is seen in between the canine and the lateral, especially in the globulomaxillary cyst. If it is seen on the posteriorly, that is behind the roots of the, or in between the roots of the incisors, it is median palatine and nasopalatine. And if it is seen in the mid palatine region, it is called as median palatine. Okay. So some of the these are some of the radiographic pictures of the same. These are all the pictures of the nasolabial cyst causing obliteration of the nasolabial fold. An occlusal view of the nasolabial cyst is taken. There will be pronounced posterior convexity. Okay. The most common ectodermal dysplasia inherited is some of the questions apart from the genetic and the genes or the pair கேக்குறது இல்லாம இந்த மாதிரி X-linked Y-linked inheritance வந்து கேட்பாங்க. Okay. So one or two questions will be like this type. The most commonly the option will be X-linked only. Okay, so whatever we see with respect to the skin and bone lesions, mostly it will be X-linked only. So have a separate list for this X-linked or inheritance. Hydriotic ectodermal dysplasia is known as Cluston syndrome. So which of the following is a feature of chondroectodermal dysplasia? So chondroectodermal dysplasia is also called as Aries van Creveld syndrome. It's a combination of polydactyly, congenital heart disease, supernumerary teeth. Which is not true for psoriasis. Auspitz sign. It is more severe in winter, symmetrical lesions, infectious. Okay. Psoriasis is something which is commonly seen in the winter season, and Auspitz signs is the scaly surfaces of the skin which when removed causes bleeding. Okay. And mostly it causes symmetrical lesion. It is not infectious. Okay. And one more feature with respect to psoriasis is there will be presence of geographic tongue or cribriform tongue, and there will be psoriatic arthritis which affects the TMJ. So the skin disease which affects the TMJ, அப்படின ஒரு question கேட்டாங்கன்னா, if there is option like psoriasis, that is the correct one. Kawasaki disease is a self-limiting disease which commonly affects the children. Okay, and it's a collagen vascular disease. So which of the following is due to an abnormality in the desmosome keratin filament complex? Okay. So here the best option would be Darier's disease. So Darier's disease, one important point which I need to tell is it is a differential diagnosis of denture stomatitis. Denture stomatitis la eppadi denture bearing area la chinna chinnada erythematous area irukumo andha madriye இந்த patientsku vandu palate la konjam areas irukum. And one important thing which I need to tell in Pachyonychia congenita is it's a combination of disorder which affects the skin and the oral mucosa. And sometimes these patients will have natal and the prenatal teeth. Okay, so this is a condition, this is a dermal condition where the patients will be born with natal and prenatal teeth. Okay. Acanthosis nigrans is associated with all increase in hormone level of that is ella hormones mein it will be elevated. Okay, hyperthyroidism, acromegaly, Cushing's, ellame. The major form of inheritance of Ehlers-Danlos syndrome is autosomal dominant triad. This Ehlers-Danlos syndrome abdina, it is rubberman syndrome abdingiradhu nyabam irukanum. And the pulp stones seen in which syndrome abdina, it is Ehlers-Danlos syndrome. Okay, default. This is some repeated question which is asked. Okay. And Gorlin-Gall syndrome, Gorlin syndrome, idellam paathom. And with respect to Ehlers-Danlos syndrome, you should remember Gorlin's sign. That is 50% of the patients with this syndrome can touch the end of their nose with their tongue, which is called as Gorlin's sign. So the Gorlin's sign is positive with Ehlers-Danlos syndrome. Which of the following disease shows become striae? It is lichen planus. Okay. So lichen planus, it is divided into 6 different types. And this slide also you can take a screenshot because there are so much of facts here. What are all the conditions and what are all the features which is seen I've given, and the syndromes associated with OLP is also given here. Okay, please take a screenshot of this. Though I'm not able to cover it, make use of it. And these are all some of the clinical pictures which shows the Wickham's striae. Lace madri irukum. Vella color lace madri irukum oral mucosa and which will not disappear on stretching. Okay, and on the gingiva it will appear as desquamation. பாத்தீங்களா ஜிஞ்சைவால பாத்தீங்கன்னா desquamation மாதிரி இருக்கும். Desquamationனா ஜிஞ்சைவால தோல் உறிஞ்ச மாதிரி இருக்கும். And the periodontal status will be mostly it will be bad. Okay. Lill's disease is also known as it's a direct question. Toxic epidermal necrolysis. It's a severe form of erythema multiforme. The loss of epithelium by rubbing unaffected skin is Mikulski's sign. Okay. The other signs also, please take it down and read it. Auspitz signs with respect to psoriasis. Tinel is something related to your calcium deficiency, and Battles is the bleeding which is seen in the mastoid process. Mucous membrane pemphigoid synonym is cicatricial pemphigoid. Okay. Which of the following is known as Hailey-Hailey disease? Hailey-Hailey disease is a severe form of pemphigus which is very familial to one particular group, and hence it is called as familial benign chronic pemphigus. Okay. Paraneoplastic pemphigus abdina, pemphigus seen along in certain neoplasm like thymoma, lymphoma, etc. Papillon-Leffery syndrome does not include. It doesn't include chronic hyperplastic candidiasis, whereas it includes palmoplantar keratosis, early exfoliation, அதாவது severe periodontitis of the teeth, and calcification of falx cerebri. White spongy nevus is also called as Cannon's disease. It is one of the differential diagnoses of leukoplakia also. It is very hereditary, whereas leukoplakia is habit related. Osler-Rendu-Weber syndrome is the other name of hereditary hemorrhagic telangiectasia. Stutz-Weber we have discussed. Crest syndrome is a combination of calcinosis cutis, Raynaud's phenomenon, esophageal webs, syndactyly, and telangiectasia. Okay. Which of the following shows multiple papillomatous nodules and multiple hamartomas? It is Cowden's. Gardner's and cleidocranial dysplasia is associated with multiple impacted teeth. Autoantibodies directed against type 7 collagen is seen in epidermolysis bullosa. Okay. So I told you this is the basal layer attached by hemidesmosome. Adukku keela vandu konjam fibers irukum, anchoring fibril, which is made up of collagen 7. If the autoantibodies are directed against this, it causes epidermolysis bullosa. OSMF is due to not smoking, not tobacco. It is only because of areca nut. Okay. Areca nut potato, there will be restricted mouth opening and atrophy of the papilla. It is a precancerous condition. Okay. It's a precancerous condition. Lesion vera, condition vera. Yes. This picture also you can take it because you will get a question like which among the following is not a precancerous lesion, not a precancerous condition. Very easy and direct questions. Here are some of the image-based questions. Symmetrical bilateral lesions in winter, that is psoriasis. A picture showing scales of the skin, that is Auspitz sign. Here you can see missing, congenital missing of the teeth, that is ectodermal dysplasia. And these are some of the signs. Though I am not able to discuss it completely, you can just take a screenshot. Idhula paadi vandu nama paathirukom. Meedi ellame you can Google it and you can see. Okay. Some of the pictures showing OSMF, the involvement of uvula, shrunken uvula, hockey stick shape uvula or bud shape uvula. Lip swelling, fissure tongue, and unilateral facial palsy is seen in Merkansen-Rosenthal syndrome. Okay. Codman's triangle is one of the radiographic feature of Ewing sarcoma also. Multiple bulb stones are seen in Ehlers-Danlos syndrome. Oral lesions associated with ulcerative colitis is Piostomatitis vegetans, which is seen as an yellow color lesions in the oral cavity. Which of the following condition has amber colored tooth translucency, blue sclera, and bone fragility? Is osteogenesis imperfecta. The antibiotic of choice in patients sensitive to penicillin is penicillin allergy irundhuchna enna type of antibiotic kudupom appadina it is erythromycin. There's no other choice. So this is important, the antibiotic prophylaxis chart. Take a screenshot. And some of the conditions, some of the dental conditions where you are supposed to give and where you are not supposed to give, that I'll be giving in the coming slides. That also you can take it as a screenshot. The conditions associated with high risk of endocarditis where antibiotic prophylaxis is recommended. Yes. Fluconazole is used for the treatment of candidiasis. Okay. The combination chemotherapy is used in tuberculosis in order to reduce the drug resistance. Local application agents to control bleeding is all except vitamin K. That's not a local application agent. It is given as an injection form. Which is caused by salicylate overdose. It is Ray's syndrome. Okay. So aspirin is contraindicated in children because it may cause Ray's syndrome. Corticosteroid is indicated in lichen planus because it is an inflammatory condition. Others are not inflammatory conditions. It's all image based. That's all. Here there is an investigative procedure, that is taurodin blue staining. Okay, a white mixed lesion where you give a taurodin blue staining so that the blue color is taken up by the dysplastic tissues and it is taken for biopsy. Okay, and here it is a surgical removal of a growth which is yellow in color on the buccal mucosa. Yellow அப்படினாலே கொஞ்சம் சில lesions தான் yellow. You can think about jaundice, you can think about piostomatitis vegetans. The other one is intraoral lipoma. Okay, and here is a picture of a elderly female patient with blister and ulcer. It is not, though it is not very clear, in elderly blister and ulcer, it is diagnosed to have mucous membrane pemphigoid. And here is a female patient with the lesions on the lip. Okay, who works in who is a daily wage worker, and most likely the diagnosis is actinic cheilitis. This is the ball tongue or anemic glossitis. Okay, papilla suttama irukadu. And these are all the images showing the drug induced gingival enlargement in an in a patient taking anti-epileptic drug. And this is geographic tongue. Okay, the loss of papilla, the multiple loss of papilla in a geographic pattern. Okay, anganga vandu loss aayirukkum. And this is a patient showing chronic hyperplastic candidiasis, and when an investigation was done, it was positive for HIV. That investigation is tried out. It's a screening test, whereas Western blot is a confirmatory test. So this is the diascopy test. Okay, for growth irukku, red color growth irukku. When you compress a slide against it, there is blanching. Blanching na vella color ah theriyuda. So that is why it is positive for diascopy or positive for the slide test appdin solluvom. Okay, so yes, thank you for listening and thank you for answering. So if you have any queries, I know the last part of the presentation was very fast. If you have any queries or if you want any explanations or slides, you can just mail me, and also kindly send a feedback in this chat itself. Okay, thank you all.